For today's meeting, Dr. Nirni and Dr. SVSS has still not reached here, but I will request Dr. Nirni to start the proceedings and invite the next speaker. We'll try to finish as much possible as on time. I'm sure Dr. Senthil would do a lot of pinch hitting in the last hour. I'm sure about it. With this, Dr. Nirni, please. We can check with them. Do we have Vamshi's presentation ready?
Yes.
Yes. So we have. So
present.
no, he's a recorded presentation. Recorded presentation. Recorded.
Recorded.
Sure. It is not coming. Still, it is not coming.
I'll discuss about 2 minutes.
Sure.
Yeah, good evening, friends. First of all, thank Rose for organizing such an interesting topic because hepatocellular is one of the most common disease, and unfortunately, most of this disease diagnosed in stage 3, stage 4. And we have now 3 lectures today lined up in this. The first one is immunotherapy, mechanism of action in SCC, and why immuno-oncology works in SCC by Dr. Dattatreya. And the second lecture is systemic therapy in hepatocellular carcinoma by Dr. Amit Singhal. And the third one is TKI in SCC for the Indian subcontinent by Dr. Nikhil Gadial Patil. And we have 2 panel discussion. One is liver directed therapy by Dr. Kaushik Bhattacharya. And second one is the systemic therapy in hepatocellular carcinoma by Dr. Senthil Rajappa. Now, first we will start with Dr. Vamshi's lecture. I think this is already recorded. Dr. Vamshi Krishna is a senior medical oncologist and director at AIG Hospital, Hyderabad. Voice.
And welcome to this meeting and treatment of combinations for now Right, and we see almost in representation to the same kind of area. The interesting thing is that we are wise because we can cover and even today it is pretty much useful. It is still showing where we are in our treatment line. Of course, there is a little blurring of lines nowadays. You have a lot of overlap. Nowadays, or we have slowly the adjoint that is speaking into this intermediate state as well as the and in the future, I'm sure we will do that. Coming the advanced level, they a lot of score on the weeks in a few years time. So very hardly have one of these now they have multiple options and multiple options. So maybe we have a separate of this. They are indicated that the or and for application already have. So it didn't work out for everyone. Actually, it couldn't be because it's not so big. And then taking the I think there are many reasons that we make up to the so when these the kind of creation of religion, importantly was this defines the type of use case. Now, as we are more accustomed to see here, technologies we have to diagnose and look at these orders now. I think we look at the in general, we will find the different modalities to provide many of the information we would tend to like this. But CPS is really crucial. There are nothing more data information and we can have CPS which is high, which is CPS and anything more than B7. In those cases, the treatment really is kind of missing. Irrespective of the size, irrespective of unless the localized treatment for anything about this stage is very possible. And this it goes to today, whether it's therapy, whether it's yes, it's actually crucial and be a part of the usual work. Similarly, performance status is something that is important because the first issue is poor performance status usually always of course, you need to look at the cancer symptoms, long-standing symptoms, but any worsening of symptoms and possibly need to be performance status. If you have a performance status, really, this treatment are not really important. Coming to the biomarkers, we look at looking at your functions and of course the chemo AFP and maybe your data is something which is deep done or different I think more controversial always related it is sometimes related with AFP knowledge so it is an indication but most important of course can be simple diagnosis of the now, usually, with those patients like this, completely if you taking item of evidence, any area which is important and has to go for a diagnosis. If you were important points. We need to do this okay, able to manage screen and patients who are high, there is something that actually was taking the brain of people. Not be a function we do not need to we have we put this completely towards the feelings Now, there are certain centers we want to be in, but for the translation. We are possibly one of the centers we go on this family, we do production of the text. Even being that we are very confident because we do doing this. On the flip side, we do sometimes rare occasions where one of the elements is what I mean, may be a possibility, but when you go back, I don't know about this. Or the percentage one, this is not very as well as 10%. And again, I think the inclusion of those that needs to be given. If you are whether this is confident, facility or enough, so it's not really. When you start looking at this image, it should be a fight between now, when we are where we would like to know which one where the answer will be to be confident and regular confidence. If there is found out whenever you might have extra reason, I was not only going to not extra these are required sometimes once for the one that is kind of is the one is clear and has a learning way. That certain many of the are not as well as the stand of a river and with the utilities. Important is the duration people say CD component will remain bottom of it. So, give a choice, go ahead, put CD stand in this world. If there is some system, you can again, conversation practice, we usually go and stand when you have a doubt or when you have planning to do it. And one area where you can push towards it. And the knowledge is not really giving up or leaving the you might keep like this to meet the other basis of mind. So the vascular hormones we also need to do any closely. So maybe nice simple. By and large, just for one example, is here, which again is the same thing. There is a positive or suspicion. Go ahead and do it. Now the imaging again is coming only as an secure MRI. I look for the direct stroke. Definitely so there's a doubt. Go ahead. That's how it works. One of the most important things that we need to remember is the body security. The system organized even oncology, certain advancement in that, pathologists and radiologists around the country who decide on it. This is not just something that is logical, you actually go ahead and there are several studies which say that we do and only then so something about policy. We need to ensure the approach and go on based on that. Thank you.
Thank you, Dr. Vamsi, for your excellent lecture. Now I will invite Dr. Satya Dattatreya. He will be a senior, is a director and head department of medical oncology, Renova. Hospital, Hyderabad. So he will be discussing about immunotherapy, mechanism of action in SCC patients.
Thank you so much, and a very good evening to one and all. Can I have my slides? So before we listen to Dr. Amit Singhal and get illuminated about how we clinically can further improve our patients' treatment of hepatobiliary malignancies, let's try to understand why immunotherapy and immunotherapy plus anti-VEGF treatment can work. Can we have the full slide or it's like this only? Okay. Excuse me, can this go away? Can this go away? Oh, actually, sir, this one is lights on. We take this can. Okay. We minimized. This one. That's it. Yeah. Okay. So I'll try to answer 5 questions or 6 questions, and that should possibly let us know why we are seeing that atezo plus bev combination probably works better in HCC patients than, say, for instance, sorafenib or lenvatinib. So the first question we need to answer is, how do I change the slide? Number 1 is VEGF overexpressed in HCC. So I think it was in 2008 sorafenib got approved. And sorafenib was thought to work in HCC essentially because of its anti-VEGF activity that was proposed as the mechanism of action why sorafenib works in HCC. So it has anti-vascular activity, and that's why VEGF is overexpressed in HCC indirectly. But having said that, many other drugs targeting VEGF didn't actually work in HCC in various randomized phase 3 trials. And therefore, for a long time, sorafenib alone remained the treatment of choice unless we had the advent of lenvatinib and then the combination of atezo plus bev. But what's important to know is that VEGF promotes angiogenesis and VEGF also promotes vascular permeability. And the very fact that sorafenib works tells us that VEGF is overexpressed in HCC. The only point is, after a period of time, tackling the VEGF doesn't really help. And so we have short progression-free survivals. So answer number 1, VEGF is overexpressed in hepatocellular carcinoma. Number 2, is VEGF an immunosuppressive factor? So what happens is overexpression of VEGF by the tumor cells leads to the antigen presenting cells or the dendritic cells not getting matured. So it prevents maturation of dendritic cells or the antigen presenting cells. And immature dendritic cells, they keep on elaborating a molecule called as 2,3-dioxygenase. And this enzyme inhibits the cytotoxic T cells. So cytotoxic T cell activity goes down. Cytotoxic T cell proliferation goes down. So immunosuppressive activity of VEGF. Number 2, because VEGF is immunosuppressive, it also tries to bring in more immunosuppressive cells into the tumor microenvironment. So you have more Tregs or T regulatory cells increasing, and you also have an increase in number of MDSC or myeloid derived suppressor cells. So on one hand, the cytotoxic T cell activity is going down because the immature dendritic cells are elaborating more and more 2,3-dioxygenase. And on the other hand, the immunosuppressive T regulatory cells and the myeloid derived suppressor cells are increasing. And all of this will lead to cytotoxic T cells going down. And so the remaining cytotoxic T cells the VEGF also tries to increase the expression of the immune checkpoints on them. So more PD-1 and more PD-L1. And that's one reason why targeting PD-1, PD-L1 makes sense. So VEGF on one hand is overactive in HCC and VEGF is also immunosuppressive. Third question, why anti-VEGF therapy alone? For instance, why bevacizumab alone does not help? Or sorafenib, why is the antivascular activity not able to keep the disease in check for a much more longer time? When you start targeting the VEGF for a long time, excessive pruning of the tumor vasculature, excessive cutting of the blood supply tumor vasculature over time starts aggravating hypoxia in the tumor microenvironment. And these hypoxic cells, these dead cells, they start producing a compound called as adenosine, and adenosine strongly impairs the development of effector T cells. It impairs the activity and starts killing the cytotoxic T cells. So a vicious cycle has now been generated. And that's why immunosuppression after anti-VEGF therapy is essentially happening because of more and more increased tumor hypoxia. And that's one reason why they realize that you need to titrate the dose of the anti-VEGF treatment to a dose which can produce a fine balance. And in clinical trials, that dose came out to be 15 milligram per kg body weight. So that's why when you use a long-term anti-VEGF treatment, you are pruning the tumor vasculature for a longer time, and that leads to more and more dead cells, and these dead cells starts producing more and more adenosine, and adenosine is harming the cytotoxic T lymphocytes. So impaired dendritic cells, immature dendritic cells are producing more 2,3-dioxygenase. Number two, dead cells, dead tumor cells are producing more and more adenosine. So these two are responsible predominantly for the cytotoxic T lymphocytes either dying, or even if they're ineffective. And on top of that, they're elaborating more and more PD-1, PD-L1. So that's the three questions answered. Now, are HCCs immunogenic or are HCCs potentially immunogenic? We read in RCCs about case reports of RCC being sometimes undergoing spontaneous tumor regressions. Case reports again, have we seen the same thing in HCC? Spontaneous regressions have indeed been shown in various case reports of patients who had hepatocellular carcinoma. If you operate and then you find more CD8 positive T cells in that resected specimen, these patients have better survival. There's some case reports on that. And thirdly, if you also do radiofrequency ablation or give ethanol percutaneously as local treatment, when progression happens, and if the biopsy then shows more T cell infiltration, these patients respond better. So if there is T cell infiltration, then it implies that these are potentially immunogenic or immunogenic tumors. Classical being spontaneous regressions have been seen. Number two, if you operate and then resected tumors, you check for CD8 positive T cells. Those patients who had more CD8 positive T cell infiltration were patients who had better long-term survival / cure rates. And so do HCCs have immune evasive mechanisms, or do HCCs have anti-tumor? If that's the case, then using immunotherapy makes sense. Liver is the front line. Whatever you eat, along with the food, we also take toxins and pathogens. And so liver is innately tolerogenic to all these toxins and poisons. So the liver immune system has evolved to be tolerant. And that's why the liver predominantly has a tumor, as a microenvironment and a macro environment, which innately is immunosuppressive. Otherwise, you end up having a lot of hepatitis because of autoimmunity. So by default, liver anatomically and physiologically is the front line to all the toxins and pathogens, and therefore it has an innate tolerogenic nature. The Kupffer cells are the liver macrophages. And these Kupffer cells have high they eliminate the high affinity antigen specific CD8 positive cytotoxic T lymphocytes, especially in HCC, and that's seen in hepatitis B virus related HCCs, where Kupffer cells are eliminating the cytotoxic T lymphocytes. So hyperactive tissue macrophages. The dendritic cells are the antigen presenting cells in the liver, and these dendritic cells in HCC are hypoactive. So you have an impaired immune system going on in and around the liver tumor. On one hand, the tissue macrophages, Kupffer cells are hyperactive. On the other hand, the dendritic cells are hypoactive. So impaired defense mechanisms. And this therefore collectively leads to the liver microenvironment, the A there being tolerogenic. On the other hand, the antigen presenting cells are malfunctioning. Kupffer cells are hyperactive, dendritic cells are hypoactive. And these two will lead to emergence of lot of immune suppressive cells. And that will lead to the cytotoxic cells ultimately getting exhausted. And the remaining cytotoxic cells are therefore upregulating the immune checkpoint molecules. And that's why it makes sense to use anti-PD-1 bar anti-PD-L1 antibodies as immunotherapy. And that's why when you combine both of them, you are normalizing the tumor microenvironment, and you are also targeting the PD-1, PD-L1 overexpressed either the tumor cells or the immune cells. And this leads to the combination working better than either of them alone. And therefore, atezolizumab plus bevacizumab works in HCC for a much more longer time than either sorafenib or lanmatinib, because they predominantly are looking at only the VEGFR, etc. And that's why, to conclude, bevacizumab promotes maturation of dendritic D cells, and mature dendritic cells will not produce 2,3-dioxygenase. Therefore, cytotoxic T lymphocytes are not harmed. Number two, atezolizumab promotes T cell activation because it causes the co-stimulator B7.1 to be overexpressed. Thirdly, bevacizumab is normalizing the tumor vasculature, and at the same time, the dose of 15 mg per kg body weight will not let more and more dead cells crop up. So pruning is not happening. Therefore, you don't find more and more production of adenosine. And if adenosine is not high, the cytotoxic T lymphocytes will not die. And then atezolizumab further works to make the tumor immune cells, the immune cells works on the tumor. So that's the way how combining checkpoint inhibition with VEGF blockade targets multiple steps of the cancer immunity cycle. Thank you so much.
Thank you, Dr. Dattatreya. Now the next lecture is by Dr. Amit Singhal. He will be discussing about systemic therapy in hepatocellular carcinoma. Dr. Amit Singhal is a professor, Department of Internal Medicine and Division of Digestive and Liver Disease, UT Southwestern Medical Center, USA, and is certified by the American Board of Internal Medicine in gastroenterology and transplant hepatology. He is an expert in hepatocellular carcinoma and serves as the medical director of the UT Southwestern Liver Tumor Program. He is a vice chair of the Practice Guidelines Committee, and he serves on the International Liver Cancer Association Executive Committee. And Dr. Singhal research focus on diagnosis and treating liver cancer before it becomes incurable. He has published more than 200 articles in many peer-reviewed publications. And he is an associated editor for both clinical gastroenterology and hepatology and seminars in liver disease. And he is a recipient of Investigator Award from the International Liver Cancer Association and the American Gastroenterology Association. And he recently received the Blue Fairy Award for excellence in liver cancer research by Liver Cancer Patient Advocacy Group. Now I will welcome Dr. Amit Singhal.
I'd like to start by thanking you for inviting me here, and also Roche for organizing the event. I'm excited to talk to you today about systemic therapy and HCC. I think we've heard some excellent talks to start the evening in terms of how we diagnose HCC, our sort of general algorithm, and then we heard an excellent talk in terms of the preclinical rationale for how we are, why we are where we are today in terms of having atezo-bev in the first-line setting. So I wanted to go through, and I'm going to really talk about some of the history of where we are in HCC, and then once again, the novel therapies that we have in the first-line setting. So here we can see my disclosures. So to start with, I think it's always important just to think through the epidemiology. And once again, we've heard some of this, but HCC really is a global problem here from, it's the third leading cause of cancer-related death worldwide. When we take a look at this, you can see here, India compared to other parts of Asia and Africa currently appears to be a lighter shade of red. Although I would argue this really is probably due to undercapture of some of the cases that we see here in India. And there's, and anyone who practices, I think, is probably seeing more and more cases over time. And I think probably this is underrepresenting the true burden of HCC in India. The other thing that I think is worth noting is that this is one of the few cancers where the incidence to mortality ratio remains near 1. So outside of a few cases here and there who can undergo curative therapies like liver transplantation or surgical resection, most of the people who develop HCC at this time currently still succumb to the disease. And so this is really where we need to do better in terms of our therapeutics for HCC. And it's one of the main reasons why we're so excited about the advances in terms of our systemic therapy landscape. Once again, a slide you've seen in terms of the BCLC staging and treatment allocation system. So I won't go through this in extensive detail, but I think the first thing to point out is that, once again, if we find these patients early, we have curative therapies available: surgical resection, local ablation, liver transplantation. And these are the therapies where we see a median survival over 5 years, if not 10 years. And so early detection, these referrals for curative therapies continues to be very important for these patients if we find them early. The other thing that's worth noting here is that when you take a look at the bar for systemic therapy, you see that the bar for systemic therapy is no longer just under advanced stage disease. You see systemic therapy also being allocated to those patients with large intrahepatic disease. And this really highlights the advances we've seen with systemic therapy, that this is now the recommended approach for patients with large intrahepatic disease. The BCLC, as you can see, now incorporates this newest systemic therapy options. So not just sorafenib and lenvatinib in the frontline setting, but also incorporating immune checkpoint inhibitors, including atezo-bev and durvalumab as being the preferred first-line therapies. So if you have people with systemic disease, one of the first questions you should ask yourself is, can I use immunotherapy in these patients? And so, atezo-bev, durvalumab being the preferred options. And then if that's not feasible, then moving on to TKI-based therapy with sorafenib or lenvatinib. And you've already heard why this is so important in terms of the ability to maintain immune responses in these tumors, continue to have activity, and prolong progression-free survival and overall survival for these patients. Here you can see the treatment landscape, once again, really showing you how we've progressed in our therapeutic advances for both first-line and second-line therapies. So sorafenib, as we've heard, being the historic therapy, shown to be a benefit in the SHARP trial in 2007. We waited a year before we had our next positive trial in the first line setting. So 2018, we had the REFLECT trial. So lenvatinib versus sorafenib, showing significant improvements in progression-free survival and responses, but non-inferior survival. So really the survival appeared very similar between the two agents, 13.5 months versus 12.5 months. It was not until 2020 with the EMBRAVE 150 study that we saw our first therapy that showed a superior survival to that of sorafenib. Median survival, 19.2 months versus 13.5 months, the highest survival we've seen in the frontline setting, and setting the bar now at this 19-month mark. In 2022, we saw the Himalaya trial, durvalumab and tremelimumab in the frontline setting, median survival 16.5 months versus 13.5 months. Once again, another trial that shows superior survival in the frontline setting with a combination of a CTLA-4 and a PD-L1 in the first line setting. So going through these trials, I think here you can see the data from the SHARP trial, sorafenib showing superior survival versus placebo, 10.7 months versus 7.9 months. And then showing data from the REFLECT trial, lenvatinib versus sorafenib, non-inferior survival compared to sorafenib. You can see the curves nearly overlapping. And really the benefit of lenvatinib was showing higher responses and higher progression-free survival, but unfortunately did not translate into higher overall survival. As you heard about, now we've gone into an era of immunotherapy. Our first experience with immunotherapy in HCC was with single agent PD-1 inhibition. So with nivolumab. Nivolumab in the phase 2 study showing durable responses in about 15% of patients. But unfortunately in the phase 3 study, failing to show a significant improvement in survival, 16.5 months versus nearly 15 months. And so once again, the conclusion of this trial is that single agent PD-1 inhibition is not sufficient to improve survival for patients with advanced stage HCC. And we've already heard once again, this preclinical rationale for why we need to combine therapies. I'm not going to go through this slide in detail. We've already heard sort of the preclinical rationale for this. But I think in short, I would say that our understanding of VEGF inhibition has changed. Previously, we thought this was really related to a direct cytotoxic effect or a cytostatic effect. And I think now we're starting to realize the immunomodulatory characteristics of VEGF inhibition and how this can augment immune responses when used in combination with immune checkpoint inhibitors. And I think that's really the sort of strength of VEGF inhibition at this time. Now, in terms of the other combination that you can see in the frontline setting, we also know that CTLA-4, so double checkpoint inhibition, can also augment immune responses by increasing your T cell repertoire. And so on the right-hand side of the slide, you can see a figure that illustrates why combination CTLA-4 in combination with PD-L1 inhibition in the frontline setting can increase your T cell repertoire, increase T cell activity, and also induce prolonged progression-free and overall survival. So, moving that, preclinical rationale now into, clinical data, the first thing that we see is, the comparison of atezolizumab and bevacizumab versus atezolizumab monotherapy in terms of looking at the phase 1b study. So in terms of the phase 1b study, there were 159 patients that were randomized to atezolizumab plus minus bevacizumab. And once again, this really shows you the benefit of adding that bevacizumab instead of just using atezolizumab monotherapy. So the progression-free survival significantly better for the combination than atezolizumab monotherapy, 5.6 months versus 3.4 months. And in subgroup analyses, this benefit of adding the bevacizumab was consistent across all of the subgroups. And so I know that there is sometimes concerns of like, do I need to use the bevacizumab? Can I get away with using atezolizumab monotherapy? But the phase 1b study really shows that there is a benefit of really using the combination not just using atezo monotherapy. Now, because of this phase 1b study, the combination of atezo-bev was then moved into the phase 3 study compared to sorafenib. And you can see here, as I referenced before, in the phase 3 study, the IMbrave 150, we see a median survival of 19.2 months. This is in the updated analysis published in Journal of Hepatology this past year, and continues to set the landmark where we are right now, the benchmark. 19.2 months is the highest overall survival we've seen in the frontline setting for patients with advanced stage HCC. 34% reduction in mortality compared to sorafenib. The other thing you can see here is you can see responses in 30% of patients, despite these patients having advanced stage HCC. 8% having complete responses. So these are patients with metastatic disease or main portal vein invasion, where you can see complete responses in nearly 1 in 10 patients. That's how potent this combination is. You see stable disease in an additional 44%. So overall disease control in nearly 3 in 4 patients. Once again, a very potent and effective medication. The other thing is, compared to TKI therapy, these responses are durable. So, TKIs, I think lenvatinib, we know does induce responses, but those responses tend to be more short-lived. Once again, as we heard, you then lose your responsiveness to TKI therapy, you lose your responsiveness to VEGF inhibition alone, and thereby then have progression after a short time on this therapy. But by combining this with PD-L1 inhibition, you really induce durable responses in a sizable portion of patients. The other thing about atezo-bev compared to TKI therapy is that you have significantly better preservation of quality of life. So very good AE profile and very good quality of life, where you see quality of life preserved for over 11 months in the atezo-bev arm, compared to only 3.5 months in the sorafenib arm. And here you can see the AE profile. So when you take a look at the grade 3-4 adverse events, outside of hypertension, grade 3-4 AEs happening in a small proportion of patients. Of course, with bevacizumab going into the clinical trial, there was some concern maybe we would see GI bleeding. And because of this, the IMbrave 150 trial required all patients to undergo an upper endoscopy within 6 months prior to enrollment. Any patients with high-risk varices were treated or excluded from the trial. And with that careful patient selection, you can see GI bleeding happening in a small minority of patients, only 7% of patients. So I think this is important for us to do. Atezo-bev, we know you can have very low rates of GI bleeding, but I do think this careful patient selection, doing the upper endoscopy, is important so we can ensure a good safety profile in our patients in clinical practice. Here you can see the IMbrave 150 study was one of the only studies to include patients with main portal vein invasion. Notably, these patients were excluded from the REFLECT trial, but they were included in the IMbrave 150 study. So this is one of the few trials where we have data for efficacy in patients with main portal vein invasion. And you can see here in those patients with main portal vein invasion, you see similar efficacy of the drug, hazard ratio of 0.62. And so atezo-bev improves overall survival and progression-free survival in these patients with main portal vein invasion. Now, the one thing to note is that these patients with main portal vein invasion did have a higher proportion of GI bleeding. And so once again, highlighting, we should be careful to do patient selection in all of our patients, but particularly these patients with main portal vein invasion, important to do the upper endoscopy. And if there's any concerns, make sure the varices are adequately treated prior to initiation of atezo-bev. Now, the nice thing is atezo-bev has been on market for 2+ years now. And so we now see real world data coming out from multiple centers. Here you can see data from the AB-REAL study, multi-center, multinational cohort of 296 patients treated with atezo-bev in the frontline setting. And you can see here that in this cohort of 296 patients, well, it's hidden by the bar, but the survival for patients in this AB-REAL study was very similar to the data presented in the IMbrave 150 study, where the real world survival of these patients in the AB real study approached that of 16 months, I think right around 15 and a half months. So overall, the effectiveness of this regimen in clinical practice appears to be preserved in this cohort. The other thing that was worth noting in the AB real study is that the proportion of patients having adverse events, grade 3, 4 treatment-related AEs, as well as bleeding events, very similar to the clinical trial. So when we apply this to our patients in clinical practice, the safety profile is preserved. Now, we also see data from India, and so this is data coming from Anand and his group. This is basically a retrospective cohort study, 67 patients treated with atezo-bev in the frontline setting, majority being NAFLD etiology and 3/4 of them being BCLC stage C. You can see overall the median survival of these patients 12 months. But this is related to a high proportion of these patients having more advanced liver dysfunction. When you take a look at those patients with Child-Pugh-A disease, the median survival was 21 months. So almost exactly the same as the IMbrave 150 study, if not slightly higher than what was reported in the clinical trial. Objective responses being seen in 40% of patients, even higher than that reported in the IMbrave 150 study. So the efficacy appears to be preserved in clinical practice, and so seeing similar effectiveness. Also, the safety profile, very similar here. Grade 3, 4 adverse events, only 21% of patients, including only 12% of patients with Child-Pugh-A disease. In this cohort study of 67 patients, only 2 GI bleeds, 1 in a patient with a history of variceal bleeding who would have been excluded from the clinical trial, and the other in a patient who had main portal vein invasion. So these high-risk patients, but otherwise, careful patient selection, very low risk of GI bleeding, good safety profile, good effectiveness in an Indian patient population here locally. Further, Anand has also generated data from a systematic review and meta-analysis of the literature here. You can see progression-free survival across several different studies, across several different centers. And you can see that the progression-free survival, very consistent across studies, very consistent, including consistency with the data reported in the initial clinical trial. You can see highlighted by the rectangle. Here you can see data for overall survival from this systematic review and meta-analysis. So you can see overall consistency across those real-world data. With the real-world data, really the pooled estimate showing us overall survival right around 15 to 16 months in clinical practice. Slightly lower than that of the IMbrave 150 study, largely related once again to inclusion of patients with Child-Pugh-B disease. So expansion of who we use this in clinical practice. But I think very similar to what the data that I just showed from the Indian population, if you include the subset of Child-Pugh-A patients, it becomes much more close to what we observed in the IMbrave 150 study. So effectiveness showing very good data in clinical practice. Now, the newest regimen that we have that has been reported, not yet approved here in India, but we've seen the data from the Himalaya study, combination of durvalumab and tremelimumab. So CTLA-4 plus a PD-L1 in the frontline setting. In this regimen, tremelimumab, the CTLA-4 inhibitor, was given once upfront as a priming dose, and thereafter the durvalumab was continued monthly. So the tremelimumab was only given once as a priming dose. And here you can see in this study, the STRIDE regimen, single tremi, then given repeated durvalumab, improved overall survival, 16.5 months versus 13.5 months in the sorafenib arm, 22% improvement in overall survival. The other thing that I think is worth noting from this trial is that the follow-up is 33 months. So it allows us to give an estimate of what you expect with these immune checkpoint inhibitor combinations with prolonged survival. 3-year survival with immune checkpoint inhibitors in the frontline setting, 30%. And so I think that's really one of the beauties of these immune checkpoint inhibitor combinations, is that you raise the tail of the curve and you induce long-term survival. And so I think this is really, once again, part of the rationale for using combination immune checkpoint inhibitors, atezo-bev, durvalumab in the frontline setting. So STRIDE also very well tolerated. You can see the AE profile here, grade 3-4 adverse events, 25% treatment-related adverse event leading to discontinuation in only 8% of patients. Now, there have been data that I think, as some of you are aware, comparing atezo-bev versus lenvatinib in clinical practice. So here you can see one such study that took a look at a study period of 2015 to 2022. And the choice of therapy was left to provider discretion when both, after both were available. So in the early period, 2015 to 2020, those patients were treated with lenvatinib because the atezo-bev wasn't available. And in the latter period, it was really provider choice. And then they used propensity weighted analysis using a propensity score adjusted for those factors that you can see listed there. And overall, you can see that the time to progression, 8.2 months with atezo-bev compared to 6.3 months with lenvatinib. So hazard ratio of 0.82. However, when you take a look at this overall survival, atezo-bev 16.4 months versus lenvatinib 15.8 months. Now, some have interpreted this as suggesting that these two therapies are equivalent. But I think that we have to remember that this is not a randomized control trial. This is propensity weighted analysis. Now, there's a lot of things we can do statistically, and we can adjust for many factors. However, I think it's worth noting that no matter how well you try to adjust for these factors, there's still residual confounding. And so when you take a look at this, for example, they have not adjusted for portal hypertension. And we've already talked about that, the fact that patients with significant portal hypertension, large varices, these red whales, those patients will go to lenvatinib over atezo-bev, history of variceal bleeding. And so these kind of factors, even though you think that they've adjusted for propensity weighted analyses, there's no way that you can adjust fully for all of these different factors. The second is that there's still a channeling bias. And so what this means is that this provider discretion still, even when you take a look at these clinical factors, there's still that provider bias of choosing one therapy over another. And so those patients are inherently different, no matter what you try to do. So the only way you can really do these kind of comparisons is a randomized trial, and there's no randomized data. Third, and this is the final thing that I'd say, is that when we do this, you take a look at these analyses. Because lenvatinib has been available for longer, you get more robust estimates for survival over time because you have more patients being followed. Because atezo-bev has only been available for the last couple of years here, you get a lot of censoring. And so the estimates in terms of what happens after a year or a year and a half become very inaccurate. And so overall, the median survival and the estimates beyond that year mark become relatively unstable. And so you don't actually know where atezo-bev will lie. And so I would honestly say that this is hypothesis generating at best. And so, we do need further data here, but I think it would be dangerous to say that these therapies perform the same based on a retrospective analysis. I think this is hypothesis generating. Likewise, hypothesis generating, but I think we need to get these kind of data into the field. This is a network meta-analysis taking a look at the phase 3 trials, very similar in terms of trying to adjust statistically and trying to make indirect comparisons. When we do these indirect comparisons, you can see here atezo-bev being compared to the alternate first-line therapy regimens, durvalumab and lenvatinib. And I'm going to move, bottom up. So sorafenib, we have a large phase 3 trial. We know it's superior. Lenvatinib, we talked about, we don't have direct comparative data, but more indirect data. But these indirect data suggest that atezo-bev is superior to that of lenvatinib. Taking a look at these network meta-analysis from the phase 3 data, hazard ratio 0.63. Durvalumab, these indirect comparisons show that atezo-bev appears to be better, although not statistically significant, hazard ratio 0.74. So overall, once again, I think what we're going to be faced with is coming up with more and more indirect data. And then as these data come around, we'll then have to be forced with these decisions based on these indirect comparisons. But I think too early for us to say equivalent or superior. But I think overall, what we can say right now is the data that we do have suggests that atezo-bev is a very potent medication. And based on the randomized data that we have, we do know that lenvatinib was non-inferior to sorafenib and atezo-bev was superior. So based on these data, this is the regimen, this is the sort of algorithm that the AASLD has recommended. So the recommended, if you are considering systemic therapy, we say you should ask yourself, can this patient receive immunotherapy? If, and you know, the main things that we thought that were important here is autoimmune disorders, so significant autoimmune disease, or a history of transplant. If the patient does not have a contraindication to immunotherapy, then that patient should be started on immunotherapy in the first-line setting. The next question that you ask yourself, moving down the left-hand side here, is this patient at high risk of GI bleeding? If that patient does not have a high risk of GI bleeding, then the recommendation was to start atezo-bev. If that patient has a high risk of GI bleeding or other contraindications to bevacizumab, proteinuria, significant cardiovascular disease, etc., then you can consider alternate immunotherapy, including STRIDE. I know not yet approved here, but when it does get approved, these would be great patients to start the STRIDE regimen. Now, if that patient has a contraindication to immunotherapy, then TKI therapy would be very appropriate for that patient. Now, when you're thinking of those patients for immunotherapy and you're thinking between these different regimens, it is important for us to screen for varices, as we've talked about, and that screening should be done with an upper endoscopy. We cannot use non-invasive measures. So, you know, for those that know the Baveno criteria and in the assessment of varices for patients with cirrhosis, this does not apply for our patients with HCC, does not have that same negative predictive value. So the only way that we can assess for varices right now is to do that upper endoscopy. For those patients with varices found on the upper endoscopy, we do not know the optimal management of those varices. Right now, the AASLD says you can consider either banding or beta blocker therapy. We don't know the optimal strategy. But if you do banding, we do recommend waiting at least 2 weeks after the banding prior to initiation of atezo-bev because of the possibility of banding ulcers and a higher risk of bleeding shortly after doing the banding. In contrast, if you're in a rush to start the atezo-bev, you could start a beta blocker, and that won't have the same issue of bleeding shortly thereafter because you won't have those banding ulcers. Of course, we have sequential therapies that have been shown to be of benefit after sorafenib. Now that we have atezo-bev or durvalumab in the frontline setting, we are forced to come up with a different algorithm. And our typical algorithm after atezo-bev or durvalumab in the frontline setting is to then use sorafenib or lenvatinib, typically lenvatinib in the second line setting, and then to use prior second line in the third line setting. So our typical algorithm after atezo-bev or durvalumab is lenvatinib followed by cabozantinib in the second and third lines respectively. One of the controversies in the field is, does liver disease etiology matter? And so I think many of you are aware of the data from Matthias and Joseph's groups in terms of showing potential differences in immune checkpoint inhibitor efficacy based on etiology. Here you can see one study in gastroenterology that suggested that the efficacy of immunotherapy is less in patients with non-viral liver disease. Of note, you can see here on the right-hand side of the slide that this analysis was subsequently repeated with the more recent data, including data that have come out from more recent studies, including LEAP, Rationale, and Himalaya, Cosmic, etc. And you can see here now the efficacy of immunotherapy in hepatitis C, hepatitis B, and non-viral liver disease, all showing a benefit of immunotherapy. And so I would argue at this point, liver disease etiology should not be a factor in terms of choosing immunotherapy or not. So even when we see NAFL patients, you should still, if possible, reach for immunotherapy as your preferred agents in those patients who otherwise don't have any contraindications. In terms of IMbrave 150, there's also a post-hoc analysis of this, of the IMbrave 150 data recently published in Gastroenterology, I think just came out this month or last month, taking a look at those patients with metabolic associated fatty liver disease patients with viral liver disease and alcohol, and you can see nearly overlapping lines. So the efficacy of atezo-bev appears consistent across etiologies when you have more granular data. Last couple slides here, I think we are now seeing systemic therapy being evaluated in the earlier stages of disease. So we saw the role of adjuvant therapy in high-risk patients recently shown here in the IMbrave 050 trial, randomized trial in patients at high risk of recurrence after resection or local ablation, randomized to atezo-bev for 12 months or active surveillance. And we see here that the adjuvant immunotherapy, atezo-bev, significantly improved recurrence-free survival. So at the 12-month mark, we see recurrence-free survival of 78% versus 65%. Now, even though you see these curves start to converge at latter times, this is related to the relative immaturity of the data right now. The median follow-up is only 17 months. Lots of censoring happening around that 15, 17, and 20-month mark. And so I would argue that right now we have to wait to see if those curves continue to be separated for long-term benefit, but we do know that this improves recurrence-free survival in the short term. Positive trial, and at least in our center, we have started to use adjuvant atezo-bev in those patients who are high risk of recurrence based on these data presented at AACR. Now, I think that this will raise questions about, what do you do in terms of treating patients who recur after atezo-bev in the adjuvant setting, whether you recur early or late. I think our current recommendation is to say if those patients recur early after adjuvant therapy, then you should consider alternate first-line therapies such as stride or lenvatinib in the front lines in those patients who recur early. But those patients who have delayed recurrence, let's say 2 years, 3 years later, it would be reasonable to reconsider atezo-bev at that time. The other thing is there's increasing interest in immunotherapy prior to liver transplantation. I was having a conversation about this just prior to the meeting. These are data that you can see coming out of the Mount Sinai group, largest case series so far that we've seen. These are patients who received single agent prior to liver transplantation. And you can see 3 patients here who received their nivolumab within 1 week of liver transplant. And despite these patients receiving immune checkpoint inhibitors, even closely prior to the liver transplantation, you can see very few patients having any rejection, only 1 patient having mild rejection, no patients having severe rejection. And so this does appear safe in terms of using immunotherapy prior to liver transplantation. Also being evaluated in the intermediate stage. I think we've heard about, the fact that there is an increased recognition of case refractory disease. So those patients who continue to have disease after having chemoembolization, these patients, we need to think of having failure and then moving on to systemic therapy earlier. So you preserve their liver function and you can have good effectiveness of the systemic therapies. We also know that there is differential prognosis depending on patterns of progression, whether that's local progression or having new lesions. This has been built into the BCLC in terms of knowing this as prognostic factors, although currently doesn't drive our therapy choices at this time. The other thing is that there's being increased recognition of case unsuitable disease in this intermediate stage setting. This is a propensity weighted analysis comparing systemic therapy versus local regional therapy in those patients with large intermediate stage disease. And you can see here, those patients who are started with upfront systemic therapy did significantly better because of preserved liver function. So I think these data also suggest that this may be a preferred strategy in these patients with large intermediate stage disease. So not vascular invasion, not extrahepatic spread, but large liver localized disease. And you may be able to preserve liver function by starting systemic therapy earlier. We don't know the exact criteria, but the Apple Consensus Conference from Asia does define case unsuitable using the up to 7 criteria. So if your sum of the liver lesions plus the number exceeds 7, at least the Apple Consensus Conference suggests you should start systemic therapy in those patients at that time. This is now being moved into randomized trials. So here you can see the ABC-HEC trial, patients beyond the Milan criteria being randomized to atezo-bev versus local regional therapy. So we should have data really showing which one is the preferred therapy for these patients with large intermediate stage disease. Combination therapy is also being revisited. So I think now we know that there is benefits of a potential preclinical rationale for using these two in combination. And this is now being moved into phase 3 trials, combination of immunotherapy with chemoembolization. I would argue that this is an immature strategy to do right now in clinical practice, but is promising, and hopefully we will have data soon showing this to be of benefit. Finally, in terms of the data that we do see, we get to see TARE plus nivolumab in advanced HCC include inducing responses in a high proportion of patients, 30% published in Lancet GI and Hepatology. And so this is higher than what we previously saw with TARE alone, 21% in the SARA trial. And once again, as I mentioned, this is now being moved into larger clinical trials, and so we should hopefully have data soon. Also, data for TARE plus atezo-bev in the advanced stage setting. Once again, preclinical rationale, and so this is being evaluated in clinical trials. Also, in combination with SBRT, we see some early data coming out of MD Anderson, showing 21 patients with radiation therapy combined with atezo-bev. And you can see here the median survival 6.8 months. I think the one thing that we have to see is that does this increasing responses and potential for increasing progression-free survival, do you offset that by increased liver toxicity? And I think that's why we really need more data before we use this routinely in our clinical practice at this time. But I do think this is potentially promising, and I think we have to see what the clinical trials show. Finally, multidisciplinary care. These are complex decisions. Complex decisions that shouldn't be made in isolation. And so we really need everyone to work as a team for us to make these decisions, and multidisciplinary care should be regarded as standard for these patients. Here you can see my summary, notable advances in the systemic therapy landscape, introduction of immune checkpoint inhibitors. I think we can say that durvalumab and tremelimumab and atezo-bev are our preferred first-line options in these patients who require systemic therapies. We see that these significantly improve survival compared to TKI therapies. Several second-line options exist after disease progression, and these therapies have now been moved into earlier stages of disease. So atezo-bev showing significantly improved recurrence-free survival in the adjuvant setting, and these are now being evaluated in combination with local regional therapies in the intermediate stage setting. And then finally, several studies showing a benefit of multidisciplinary care, and this should be regarded as standard for these patients. Thank you so much.
Any questions? I have one question for you. So you have presented this data about this anti-VEGF with IO in the first line. So in your practice, you still consider TKIs at all in the first line, or it's now totally out?
So
possibly not only in the city does the highest number of livers, I would assume in the country she does one of the highest number of livers. So it's nice to have her opinion here. It's in the, my thing is in the, that motivation and inspiration. Yeah. So my topic is only about the, my topic is only about the liver-directed therapies, though, it's not quite compartmentalized, and that's one of the things I'll try to make point of. That is not, sometimes you can really put them in a pigeonhole. There's a lot of back and forth that goes in. But yes, my primary aim will be to talk about the, is there a way I can, reduce this window? How to get rid of this? Can you get rid of this?
Yes, sir.
Yes, okay. Yeah. So I have decided to just take two cases. Yeah, I'll finish in that. I have decided to just take two cases to illustrate the point that I'm trying to make. Start moving. Yeah. So case one, this is an 85-year-old gentleman who was incidentally detected to have a lesion in the liver. Ultrasound shows exophytic, well-defined, rounded, heterogeneously hypertrophic lesion with mild internal vascularity. He's also having a lot of comorbidities. Asthma, there's a chronic kidney disease, very high creat, diabetes, hypertension, heart disease. Now, since there was a lesion in the liver and someone pointed that this could be a liver tumor, what kind of further investigations would you do? From the, anybody can suggest, what are the typical investigations that you do for this patient? Yeah? Yeah? Mike? There are so many medical oncologists and we're talking about liver directed. So I asked Vamshi that why do you want to have so many medical oncologists and liver directed? He said that they should know and learn. So after this, I will ask questions. So what are the further investigations? Yes. Anything else? Yes.
Yeah,
That's pretty much it. So anything else you would do? Yes. You would like to possibly do a investigation, set of investigation that point towards the risk stratification of the stage of this patient. So what are those? That apart, directed towards the XCC. That's where. Yes. Yes. So this is what we'll pretty much do. HIF, bilirubin, INR, albumin, ascites, and calorific. These are the things we're looking at. So this is what precisely the point. So if you're doing liver, this comes to your mind like a rubber stamp. If you're not doing liver, you will not think about it. Who would really think of HIF? And here is this thing. There's a high PIF, low AFP, bilirubins. I could not find in the, my resident has not entered, so I'm written to Venel, but I guess it's. Yeah, so what it is now? It's a CPSA, and we would like to do a MR. Now this patient is having very high creatinine, so we could only do a plain MRI T2, T1, and this is what it is. There is one lesion, T2 hyperintense, and there was a restriction of ADC in the 4B and one in the 6. This was the definition. This was the description here. Well-defined oval shape T1 ISO and T2 mixed signal in the 4B. And there's the most important thing is that there's a nice subcapsular bulge here. This is something that's going to come and be discussed. Another second one is the mild T2 hyperintensive, smaller one. Here's this one. This one. I understand this is not the ideal set of investigation that you can have. You would like to ideally to have a triphasic CT, triphasic MR, but because of the contrast, we could not do that. So the patient underwent an AFNA, which did show HCC. IHC was HEPAR positive. And again, as Vamshi was telling in the morning, that a lot of people get done PET CT for no real reason. This was also done for no real reason, but at least it told us that there is no extrahepatic lesions. Here we are. This is a BCLC B because of more than one lesions. How would you go about it? What are your treatment options? We have a surgeon, you have a medical oncologist, we have an IR specialist on board. How do you want to go about it? What are your treatment options? Yeah.
There are those 2 lesions I will still offer the microwave option.
Yes.
Even though there is a mild solution. But if you take a tangential approach of that, I think it can be targeted to the microwave operation.
Okay.
So with any tumor lesion, the first thing is we'll do an ultrasound and see for the feasibility of the microwave operation, and I think that.
Sure. Sure. Anybody else want to add something to this? From the radiation oncology side, you want to add something?
With all
Yeah, let's start.
the history and age, having, I don't know.
Suppose the patient is a young patient. Suppose the patient is a 40-year-old fit
The
patient.
young patient without comorbidities. He was like a start.
Yeah.
Best option. Even though it's at
Mhm.
the best option would be transplant.
Mhm.
You said it's in several forms.
4B and another is in 6A, 4A, 4B. Segment 8, I'm sorry. Yeah.
So segment 8 and 4B, okay. So the other option, like say, if he's a young guy, not willing to transplant, he's still over towards.
Mhm.
The segment 4B is quite superficial. Like, no, it's the.
Partial hepatic. Non-anatomy. Okay. Anybody who is willing to throw radiation to this patient? What would be the radiation oncologist's opinion?
Definitely microwave is the first option. I think so. The patient, if microwave is the patient not fit, is there anything that's criteria for microwave? Just in case it's not fit?
So one thing is coagulation profile.
Yeah.
The coagulation profile and that's the coagulation profile. Sometimes if the lesion is predominant exocytic, that 50% or 70% is exocytic, then the microwave becomes really challenging. And there are some techniques like artificial creation and all. But we are looking at this looks approachable in microwave, but predominant exocytic, then either taste or something like that.
Yeah, also an option here.
Yeah.
So what we
Now, this patient's mother is actually a practicing medical oncologist, and she had a lot of, patient's daughter. Daughter is a practicing medical oncologist, so she had a lot of opinion about what should be the treatment. But that aside, yes. What about RFA? Would you consider RFA for this?
There are multiple prongs which are there. Coming to the capsular lesion, we always prefer microwave.
So good. So that is, I think, one of the key things that I told you to please look at the capsule. Subcapsular lesions are not the best cases for RFA. Microwave is possibly equal or better than them. The other contraindications for RFA usually, closeness to a large vessel because there's so-called heat sink effect. SBIT, she has mentioned. What about TACE combined with or alone radiotherapy, or TARE combined with alone radiotherapy?
For less than 3 centimeter lesion, I think if it's seen from even on CT, if it's seen, I think the microwave.
Microwave will be a better option for you. What about addition of systemic therapy for this patient? Doctor.
tactics loaded for some PLS, but that we are not more than practicing. Only except that people have a progress more than 2 times stays. We are actually like.
So basically on TACE, yeah, TACE.
Yeah. I think it's.
I think it's going to see that our center, I mean, I think that we were given my patient the IR of what is going to go.
Yes.
I think the subcapsule lesion, I think our IR is somewhat more to do those stuff, and so here what we try to use is combination, so we do microwave for the other lesion, and then we tend to use a very vascular TA, so then we target the other vascular TA. So your point, I think we will do this imaging therapy, and then we will try the cessation of transplant and see.
Yes.
And it is here. I think the other thing is just keep in mind now, within table 50 stage needs the criteria for high risk of recurrence. So if the patient was not going for transplant and was getting definitive legislation, that was a pathway, the patient could then receive, your question of is there a role for systemic therapy? It's not really the way we traditionally think of systemic therapy as immediate upfront. But if you were to say this patient isn't going to transplant, I want to do ablation for both those lesions, this patient meets criteria that are in Rable 50, and then you could start intensive therapy after the setting, including current possible. So I think that's the one thing that it's going to take us some time to wrap our mind around, remembering to consider the adjunct therapy. I think most of us remember the cervical resection, but I think also because of the ablation, I think it's, I often think about it too, just take over the time to remember.
So the whole idea of putting this patient is to show that all the options listed here are valid options. So therefore, how to choose? What is your data for that? And time and again, you will see the data does not exist. You have to make sense of what data you have. Now, would it, the BCLC tells you that if it's a BCLC A, then you go for a surgery or transplant. BCLC B, this, in spite of being a BCLC B, do you think your outcomes will be different, or there's a way of selecting BCLC Bs for surgery, which ones you do, which ones you don't?
Yeah, as far as the, taking into consideration the MEL score and also the NINA criteria or the incidence criteria, this is mainly pertaining to Canada. All the data that we have are pertaining to whether we are doing better or the outcomes. But when it comes to individual funds, I don't think there is any much difference in the.
So great. So the other point is that the Milan is possibly very, very conservative. And there is one paper I'm showing you, this is last year's paper, that showed irrespective of the stage, irrespective of whether it's BCLC A, B, or C, the outcomes are not very different when you do a transplant. Now, this is again, it's a population-based study, it's not a randomized thing or like that, but this is a pointer towards the fact that possibly we're very, very conservative when we say that this patient is not fit for transplant. But what are the other things? Do you think there's a choice between TACE and TARE?
There's a recent data of the TARE was included in the BCLC.
Yes. Yes.
So that's the legacy trial.
Yes.
So what they're doing is given the median size of the tumor is around 3 centimeters.
Yes.
So even for a 3 centimeter.
Yes. So the BCLC tells you that as long as it is less than 8 centimeters in size, you can offer TARE as an option. And again, there is no great randomized trial between them. But this particular IPD meta-analysis from a lot of other non-randomized trials that shows, and this is more than 2,000 patients, that shows that there is a no difference in the overall survival, and the time to treatment progression can be actually slightly better in case of TARE. But that said, the TARE has got other challenges in terms of size, and the TARE has got other challenges. Whenever they do a TARE, you have to see whether there are any significant number of arteriovenous shunts in the liver, because the drug leaks into the lung and that can give rise to other consequences. So again and again, you will see it is the contraindication to a particular treatment that will determine which treatment you choose rather than the efficacy of a particular treatment, because by and large, from what we know, they are comparable. This is the complex arrangement. This is where we're coming back again and again and again, that you have to choose between them. There is no high level data to suggest this works or this doesn't work. Now, here, my point is that if you search this entire list with a microscope or a reading glass, you will not find the use of the word radiation or SBRT. Now, I'm very happy to have Dr. Singhal here. He could possibly give me some explanation as to why this has happened. But in my search, and this is a very famously quoted paper in All Radiation Oncology Forum, that the guidelines that are created by different bodies, they vary very, very widely. And in the context, BCLC is somewhat, should I say, crippled when they have done this. I have listed 11 different, guidelines from different parts of the world. And you have Asian, where you have basically virus-based disease, versus American and European, where you don't have virus-based disease. And you see many of the guidelines, they didn't have a radiation oncologist on the panel. And exactly those are the ones that did not recommend radiation. So my idea is that you have to understand that while BCLC, and you are so stuck up with BCLC, you tend to forget the fact that radiation has arrived, but just because it is not there in the BCLC does not mean it doesn't work. So if you're trying to understand what is the role of radiation, there's a very nice paper coming out last year, which is the comprehensive guideline for use of, I will not go into this because it's not a radiation oncology crowd, but wonderful algorithms on the basis of the existing data. And of course, there's a possibility of addition. We are not dogmatic, because TACE works in a certain way, R2 works in a certain way, and whenever you can add. And it shows that using TACE and radiotherapy is better than using, this is a randomized phase 2. It is better than, of course, now it is invalid because sorafenib is no more the first line, but you can actually get better idea. So do you do often this kind of combination, Dr. Vivek.
Definitely the article code is shunted.
Yes.
All the way before thrombus.
Mhm.
HBRT has a definitely role.
Mhm.
Because in most of our cases, the article code is shunted, we are unable to do either immunotherapies or radiotherapy.
Okay.
So now the combination therapy of immunotherapy, HBRT and the TACE or TACE is what we are.
So one question for the surgeon. When you see a patient who has undergone TACE versus a patient who has undergone SBRT as a downstaging procedure, do you find any difference in the surgery? Does it make any difference?
When they do a taste, they use RP. So we tend to be more careful when we decide to do that. With SBRT, actually, we have not found much of the radiation activity, fibrosis or anything, as far as I'm concerned, whatever drugs is clear that. So I think SBRT is more directed, so you don't actually get into the other organ as such. So I don't see much.
Good, that's a nice feedback. And I will skip a few slides and come to basically it talks about it basically tells you that the data is there, but it is not quite there. And possibly if you have a large size tumor, possibly radiation is better compared to TACE. But then again, these are all not really randomized data. There's one meta-analysis that shows that local progression is better when you are treated with SBRT. Overall survival is better when you do it with RFA. When you compare, and because again, this is very, very murky data. Similarly, there are 3 propensity-based analysis that compares radiotherapy with SBRT with TACE, and 2 of them show TACE is better, 1 of them show radiation is better. So it's how you play with the numbers. So this is the first case, and the idea of the first case is to tell you that in B, you have all options. You have to have an MDT to find out which one is not suitable for the patient and then choose. Certain there are contraindications for RFA, there's some contraindications for SBRT, there's some contraindications for TACE, and then. So this is the second case. Am I on time? Second case? Oh, I'll finish. Second case. This is a 45-year-old gentleman who had symptoms and was examined. He was diagnosed to have a CPSA. And there is this nice diffusion weighted image in the triphasic and in the arterial phase. This is pretty much on the basis of radiological diagnosis patient, and there's involvement of the enhanced lesion in the arterial area. So this is a BCLCC because of the fact that there is an involvement of the vessel. What would you do for this patient? Same question. So RPPV, if I'm not wrong. Right, RPPV, yes. Right, what is it?
So yes, because he comes to me, then obviously the transplant is
But with the portal, yes. So the portal vein involvement is not one of the things that you can take you to a surgery state, or you have to clean up the portal vein in some way. So basic question is that you have to offer some treatment at down stages. So what would be your option? Would you do RFA? Would you do SBRT for this patient, Dr. Sujana?
Yeah, it is definitely an option, but not just the primary, but the primary as well as the photometric tumor not a strong and
Okay.
so we try to downsize it and then recover the one.
What about your options of TACE versus TARE in this? TACE or TARE in this?
TARE, I mean, the radiation lobectomy we can thought of.
Mhm.
One is the TARE or TARE for the primary lesion because it's small lesion with SBR.
Yeah. So again, you see this tumor, because the portal vein is involved, you cannot do a TACE. So therefore, you have to offer TACE to the primary and SBRT for the vessel. This is kind of complex rearrangement, which you can do. What we have done for this patient is of course, this trial was not published when we treated this patient, RTOG 1112, which was published last year, actually this year, ASCO 2023. This was basically randomizing between sorafenib versus sorafenib and SBRT, 117 patients, 80% of their BCLC CPS was spread from A to C, 74% had PVTT, 2% were actually having metastatic disease. It was shown that median overall survival significantly improved when you add SBRT to sorafenib without any additional cost of toxicity. This trial was actually prematurely truncated because IMBRAVE trial came in 2021, and that changed sorafenib to atezolizumab, became a meaningless trial at this point of time. However, looking in isolation, you see you are looking at very, very high risk disease. You are looking at BCLCC, and you have a 15 months of median survival. So that shows that radiation alone, with or without any systemic therapy, has got a high possibility of control. So this patient we treated with radiation. She did the treatment. This is a technical stem jumping through. Breathhold technique was used. After 10 weeks, the AFE fell dramatically. And this is the 8 weeks PET CT, which was complete resolution. And this is very common. This is not uncommon to have very, very good, because radiotherapy, HCCs are very, very radiosensitive. In all likelihood, the dose that you give for radiation, HCC disease is well above your requirement. It's complete resolution. Same with after 4 months, the MRI shows complete clearance. Obviously, the second case was trying to point out the fact that you have an option. Even when you have a portal vein thrombosis, it's a BCLC3, BCLC-C. This patient has now become a transplant eligible patient, and you can have a wonderful outcome from this. So my point is to tell you that I feel, and I will be happy if somebody is willing to argue this with me, that the current BCLC guidelines are too conservative and compartmentalized. They're like rigid lines like this, very, very rigid lines. Whereas I think this is the reality, and this is not my opinion. This is a slide that I've taken. This is where it should be. A is clearly understood. B is a continuum that runs into C. And you possibly have to start off systemic therapy even at the B and go right up to C. And local regional therapy holds its fort slowly even up to C. Therefore, especially the intermediate risk group is where you have a combination of everything. We don't know clear answers because many of these questions are not answered through proper randomized trial. However, you have RFA, microwave, TACE, TARE, everything in your armamentarium. You have to use the treatment modality on the basis of your contraindication. And then that's what you do. So thank you very much.
Sir, I have a question.
Yes, please.
The discussion about adjuvant therapy post-stage. So are you using it as a part of some clinical trial or as a routine? So we usually now have the DFA data were presented at ASR. So we use it now at high-risk patients after resection or low. Based on the data only. Based on that data, showing the different spots. So that's been adopted in the ASL guidance that just came out. So that ASL guidance is published in last month. I think of it. Yeah. 12 months. Right. But the other, we don't really, before that trial, we were not doing actual therapy inside. So this, the prior trials were all negative. This is the first trial we have the efficacy.
To add a point from the imaging point of view, because a lot of people who see the outside, a lot of people rely on PET scan based diagnosis, but that is not right because MRI is the gold standard, and most of the patients have a background state. So what happens in background state is there's a lot of inflammation going on, and then the stage of activation of in the CAD work. So that's why you always rely on MRI than PET scan. So PET scan has a lot of background noise because liver is trying to study with a lot of glucose. So it will not give you a real information of what is happening in the liver. So that's why the MRI should be the standard of care. The standard choice of investigation whenever we see a patient. That's what I would like to.
And I will also add one more line to that don't trust any imaging before 6 months. It takes at least that much of time for the findings to stabilize. So you do a treatment, whether it's a TACE, TARE or SBRT, you go in 1 month time, you do an MRI or something, and oh, it has not worked. You have to wait for that long. Yes. Yeah. But what she's telling is that PET is not the thing. Yes, Dr. Singhal wants to add something.
People more sensitive in MR is more sensitive in smaller issues. And also some of the individual we see on CT.
So, we have a lot of lines, 3 to 5 stages of incubation, where MR is goes up and not there. So, PET scan can be used, but only for the extra part, not,
Yeah.
not to see.
I think Dr. Singhal wants to add something.
No, just in the, like, beyond 2 centers, you know.
Just
You know, the roads.
Good done.
Assuming you get it involved. I mean, and with good people reading them on. So I mean, I think it's another thing where, you know, it's funny, when you look at the data, I'm not saying it's better than CT. But most of the guidance that do one or the other, you know, because they want to make everyone do MR. Because they want to make sure you do what you do best. So if you don't want to do MR, don't try to do the MRI. But if you can get a good MRI, it's the best. So we kept it in between, where we can see the minority. I mean, we're mainly doing MR outside of those regions that are not really on which is good. So that.
Combination of what MR and CT is.
Now we are going to almost MR first.
The first line,
Then we are.
probably researchers are not to use.
Thank you very much.
Okay, we discussed that for the dinner. Thank you so much. Thank you all the panelists. And we move on to the next one, Krishnamani. Who is the next one? We think Krishnamani, you are the next one, right? Yeah. So Krishnamani is going to discuss about the systemic therapy again in BCL, CANP and adjuvant in a more of an adjuvant setting. Krishnamani.
Good evening, one and all. Thank you for the opportunity. So when I was given the topic, I was wondering, what am I going to talk on this, which we probably seldom practice clinically. So it led to me reading a bit and then learning a lot of new things, which I will probably share with you today. So this slide has been discussed many a time, but then just to rush through, we are classifying patients based on BCL A, B, C, and D. And your D patients are the ones which we commonly see in medical oncology practice, maybe, who qualify for best supportive care, who are child fugue C, who are poor performance status. And then when you go to your A and B, you talk of local or local regional therapies, and C is your advanced cases where we were giving TKIs earlier, and now atezo-bev is a standard of care. So these slides have been discussed. So we are looking at single tumors which are less than 3 in number, less than 3 centimeters, with preserved liver function, excellent performance status, where we are talking about local therapies in the form of resection, transplantation, and you have alternative treatments as discussed in the panel like SBRT, etc. When you have a multinodular or a BCLCB, as we discussed, it is either loco-regional therapies in the form of TACE, microwave, radiofrequency, TARE, etc. Now coming to the two most important things, which is rather the most important thing in the adjuvant setting. When we talk about the adjuvant setting, we are talking about liver resection or we are talking about ablation. So an R0 liver resection is recommended for tumors, single tumors in patients who have excellent liver function. Definitely they need to be child fugue A without significant portal hypertension, because they would be the best candidates. And you're going to, so they would be the best candidates, and carefully selected patients with child fugue B may be candidates. But if you, as a dictum, you would probably select child fugue A excellent performance status PS 0/1 and those who have BCLA, and you can achieve an R0 liver resection. Those are the patients whom you would try to consider for a surgery. And when it comes to transplant, you would try to apply the criteria, which are the Miller or UCS criteria, where you're looking for a recurrence which is as low as possible and expected survival of at least 5 years survival, at least 70%. So these are your two more main important local treatments or curative treatments. But the fact of the matter is more than 70 to 80% of the patients recur even after a local therapy. And that's when your adjuvant therapies kick in. That's the reason all the importance is being given that we need to use adjuvant therapy. Right now, adjuvant therapy outside of a clinical trial is not recommended, though as Dr. Amit said, they're using it in the center because of the data which we have for Atezo-Bev, which shows a RFS benefit, which we will come to in the next few slides. So why are we talking about adjuvant immunotherapy in a disease like HCC? So it's a immune-rich environment. We'll be talking about that. So this is a slide which you will see in many papers where there are multiple things which have been postulated, like if you have a CD8 or a CD3 infiltration, which that is associated with a lesser recurrence. Lesser interferon or lesser NKT cells, which independently predict recurrence or survival. Gene scores or gene signatures have been postulated, which decides or which probably tells us about the prognosis of resected HCC. T regulatory cells, myeloid-derived suppressor cells, they have been linked to OS and DFS and also recurrence after resection. So these are all the postulated immune mechanisms. It is not like there is a one-size-fits-all approach or one thing would lead to another, but these are all postulated mechanisms for why some patients do well and some patients don't do well. Now, if you look at this slide, this is all the data which is happening in the world regarding adjuvant immunotherapy after resection or ablation in HCC. It could be immune checkpoint inhibitors alone, single agent, or immune checkpoint inhibitors with VEGF inhibitors. Why VEGF inhibitors with immune checkpoint inhibitors? I'll come to later. But look at these papers here. Nivolumab in the Nivol trial. Checkmate, again nivolumab. Pembrolizumab. Go down. They're all mostly single-arm studies where they are all recent studies. Recruitment is going on. The answers will probably be there maybe in another couple of years. It is your immune checkpoint inhibitors versus placebo. And most of these trials are looking at recurrence-free survival. So the primary endpoint is RFS and the secondary endpoint is OS. If you look at the eligibility criteria, it is after initial curative treatment with resection or ablation. So your patient should be eligible for a curative therapy, which could be either resection or ablation. Child-Pugh A, ECOG performance status excellent, and preserved organ function. The exclusion criteria across the board is sarcomatous variants, fibrolamellar variants, combined HCC and intrahepatic cholangiosis, which we see, and those who have gastroesophageal variceal bleeding, ascites, or hepatic encephalopathy. So these are the key exclusion criteria. So the bottom line is we are looking at immunotherapy in the adjuvant setting, either as single agent or in combination. And the primary endpoint in most of these trials is recurrence-free survival. Many of these studies are ongoing and the data will be there in a few years to come. And we look at the last two studies, which is the Emerald and the other study, where they are looking at combination like durvalumab is bevacizumab and atezolizumab with bevacizumab. Again, the primary endpoint being RFS. Not only nivolumab, not only pembrolizumab, some other agents in the form of cambrelizumab, and then additional TKIs, not only VEGF, but even TKI in combination with ICI. Now, this is one phase 2 study which I wanted to put here, which is nivolumab in the adjuvant setting. So the inclusion criteria is what we discussed: HCC, whom you could resect, excellent performance status, single arm study, 55 patients, and the primary endpoint was RFS. So this study, the recurrence rate at 1 year was 23% compared to the standard cohort, which is 55%, 45%. So in one way, it was positive for a phase 2 trial. But the problem is the authors themselves point out that this probably works in a subset of patients of HCC whom we have to identify. So what is the rationale? The rationale for use of any of these agents is the immune microenvironment in the liver, which is an important determinant of outcome. But not that all HCC patients have a similar microenvironment, and we'll come to that. There are many immunosuppressive mechanisms present in the tumor microenvironment, which are modulated by VEGF and PD-L1. That's why your VEGF plus PD-L1, anti-PD-L1 probably plays a better role compared to a single agent immunotherapy. So dual VEGF PD-L1 blockade may be effective in reducing recurrence by creating a more immune permissive microenvironment. Now, this is a paper by Sia et al. Where they have tried to broadly say immune-wise what you would see in a HCC. You would either call it an immune-suppressed HCC, an immune-exhausted HCC, or an immune-rich HCC. Your immunotherapy works well in immune-rich HCC, unlike the two. So if your immunotherapy is not working in your HCC patients alone, if you have not combined it as a VEGF, the reason probably is it's an immune-exhausted or an immune-suppressed HCC, which close to accounts to 40 to 60% of your HCC patients. And how does the VEGF add to value? Why are we using Atezo and Bev? VEGF inhibitors work by altering the tumor microenvironment, increasing the maturation of your dendritic cells, tumor responsiveness, and infiltration by the tumor cells. Now, this is a very good diagram which I found, where you have a primary tumor at diagnosis, which explains which are the two putative ways of you having recurrence in a HCC. So you have a primary tumor at diagnosis. You have the star mark, which is a disseminated tumor cell, which is clinically not visible either on your MR or your PET, etc. You remove it with your ablation or with your surgery. And then what happens? The large red circle is gone. You have this small dot, which is not visible on your conventional scans. And then what can happen? The ideal way is we would expect our patient to be fine and healthy, but that apart, if he progresses, what happens? You can have a growth of the disseminated tumor cell. So the disseminated tumor cell, which was there earlier, which was not visible, grows, and that is a recurrence. That is a type 1 recurrence. Else, you can have a de novo carcinogenesis in the remnant liver, and the disseminated tumor cell stays where it is. So this is a type 2 recurrence. Why are you worried whether you have a type 1 or a type 2 recurrence? So there are differences in pathology, there is differences in the etiology, there is differences in probably how you treat. So the key mechanism, type 1 is due to disseminated micrometastasis, type 2, it is due to de novo carcinogenesis, the liver itself is bad. These type 1 patients have a high risk of disease recurrence because on day 1 at baseline itself, you have invisible disease, which you have not picked up. Type 2 patients are those who are usually all your patients who are cirrhotic or alcoholic liver disease. The types of treatment, what you would do, you would use anti-tumor agents. But in type 2 recurrence, you would use your Hep B, your agents directed at your hepatitis B or C, so that you reduce the recurrence in the damaged liver. When could you develop a recurrence? Shortly, 1 to 2 years after surgery on a type 1 liver, because you already have invisible cells. Type 2, you can have at any point in time, because any cirrhotic liver can grow into a cancer at any point in time. And the examples you would use here are your TKIs and PD-1. Here you would use your Hep B. So this is where your type 1 or type 2 will probably tell you what kind of an adjuvant therapy you need to use based on your expected recurrence. Now, what are all the adjuvant therapies which have been used in HCC over a period of time? It's kind for medical oncologists, HCC has been a graveyard for adjuvant therapies until recently. So you look at TKIs, sorafenib, interferon, chemotherapy, immunotherapy, loco-regional therapy. So let me just go into what we focus as medical oncologists. TKI improved RFS, improved OS, no. Interferon, dicey data, extremely toxic. Chemotherapy, no. Immunotherapy, right now on adjuvant, we'll come to that, but otherwise the data is still ongoing. And apart from that, so the only one which actually shows good data is your HBV treatment, which probably explains why we use it in type 2. Coming to my last few slides. Now, this is another graphical representation which shows how your immunotherapy works in your tumor post-resection. So once we resect or once we ablate, the antigens are coming into the stream. So the antigens are taken by the cancer antigen presentation cells or your dendritic cells, and that is aided by your VEGF inhibitors. That is point number 2. And from there, they activate and you get your T cells, they traffic, and you have an infiltration of T cells, which is responsible for your response to immunotherapy. So this slide has been discussed by way of our previous speakers, but this is your pivotal study on adjuvant immunotherapy, where post-surgery, post-ablation, no residual tumor, they were randomized to 1 year of Atezo-Bev versus active surveillance. And the result is you have a relapse-free, your recurrence-free survival benefit of 78 versus 65%. Now, the beauty is you should look at how did they select the patients? So not all the resected patients went on the trial. So who has a high risk of recurrence? Broadly, remember those people who have 4 or more tumors, those people who have tumor more than 5 centimeters, those people who have grade 3 or 4 tumors, or those people who have macro or microvascular invasion. So if I have 4 or more nodules, if my tumor size is more than 5 centimeters, if I have grade 3 or grade 4 histology or vascular inpatient, I have a high risk of recurrence and I would be part of this trial for resection. For ablation, any tumor more than 2 and less than 5 centimeters or multiple tumors. That is the criteria they have taken to put patients on this trial. More importantly, this is also a criteria which they have taken to decide how do you decide your patients on vascular invasion. So they look at the portal vein, hepatic vein, and microvascular invasion. And what are your key endpoints? For want of time, I'll be rushing through the last 2 slides. The key endpoint in all these trials, including the Zimbrave trial 50, has been RFS. The key secondary endpoints are OS, RFS as determined by the investigator, or OS at 24 and 36 months, etc. But recurrence-free survival is your key PFS. And what do we find as a recurrence-free survival? The recurrence-free survival is 78% versus 65%, giving a benefit of close to 12 to 13% for Atezo and Bev in this trial. So coming to the last line. So this was a multinational randomized study which was evaluating Atezo and Bev, and the primary endpoint was RFS, and they met their primary endpoint. And that's why it is considered that they can be used in an adjuvant setting, but though still it is still not a guideline recommended one, but yes, there is data to suggest that. So thank you very much, and if there are any questions, I'd be happy to answer. Yeah.
Thank you, Krishna. And due to a shortage of time, we'll quickly move on to my presentation. Can I have my slides, please? And I think we almost touched on almost all the aspects. And the last part of the discussion today is role of TKIs in the HCC. And I think when I was given this topic, it was about TKI in HCC, scope in Indian subset. So when I tried to understand the papers in this regard from the Indian perspective, there are very few papers in this setting. So probably what I thought was we probably will give an overview about the current standing of TKIs in HCC. In addition, in the first line as well as second line, and what Indian data we have in this particular space. Okay. Can we have the full slide, please? Yeah. So I think we are short of time. Let me start the presentation in that case. But yes, are we okay? Yeah. So we all agree that the HCC probably, when we see our patients in our day-to-day practice, it's not a one disease, but sometimes a conglomeration of many diseases, especially with the background of comorbid conditions. But more importantly, we do know that most of the patients of hepatocellular carcinoma may have the underlying cirrhotic disease, and that becomes quite challenging to treat such patients. When it comes to patients, more from the Indian perspective, and more often than not, we see the patients like this who are quite decompensated, and that's quite a challenge. When we go by the guidelines, most of these patients should be offered best supportive care. But many a times we come across slightly earlier stage patients. And what happens is when you look at the curves, now these are not the curves for the cancer, but when you get a decompensated liver, what happens? The outcome is substantially poor when you get decompensated liver, and that's almost remains the order of the day for most of the medical oncologists who are treating with such kinds of patients. Now, when you look at the history, how the patient used to be treated in the past, it's one of the very old papers where doxorubicin was tried, and you can say the survival was around maybe 10 weeks, as compared to no doxorubicin was around 8 weeks. So we can talk about 2 weeks benefit. But from that point in time till now, we have come a long way, and that has happened due to the advances mainly in the TKI space as well as in the immuno-oncology space. And we know for sure that in the last decade or decade and a half, when the real, I would say the story of improvement started with the HCC management, all started with the sorafenib with the SHARP study. And then there was a significant gap before which we could get subsequent lines or subsequent drugs which were available in the form of lenvatinib. And of course, for the second line, we do have some other drugs which I will definitely discuss in my subsequent slides. This slide has been, I'm sure must have been bombarded from all my previous speakers, but where exactly currently we have been using this TKIs the most, and it is mostly in the patients who are advanced stage disease, where it remains one of the options, especially when the patients are inoperable. And these are the patients which usually go for palliation. So the one which are highlighted over here with the yellow letters are the patients who are typically going to undergo treatment with one of these options. And here we are talking about TKI. So I will stick to that. Again, we do know that most of the patients who are advanced disease probably would go for one of these palliative approaches. But we have already heard from our previous speakers about the emerging role of drugs, especially in the adjuvant setting, in the neoadjuvant setting, in combination with the available treatments which are available like local therapies like SBRTs and so on and so forth. So if you really look at this blue triangle, even though we know that it's more to do with the extensive stage disease, but there is also some amount of emerging role in the early part of HCC management. So in the first line, we do have options and approaches. We have already discussed about adesopeptive, durvalumab, monotherapies in the initial part of the studies, and importantly, what I'm going to discuss about lenvatinib as well as sorafenib. In the second line, we do have a couple of anti-VEGFs over here in the form of cabozantinib as well as regorafenib. So this was one of the pivotal studies of sorafenib, the SHARP study, which compared sorafenib versus placebo. One of the first studies, which was one of the first drugs I am sure most of us had used in the clinical practice. And these are two positive studies of sorafenib, both compared with the placebo. One was the Asia Pacific, another was a SHARP. And here just I wanted to focus on the numbers in terms of the survival, and this around sorafenib touched around 10 odd months in this particular study. Now coming to the subsequent study, which was with the lenvatinib, which had been recently published, and here what we could see that even though the median OS was not significantly different with lenvatinib versus sorafenib, there was clear benefit in terms of the progression-free survival. And probably that was one of the reasons why the science in general has switched over from sorafenib to lenvatinib for almost all the practical set of patients. And that has been the case for a period of time. But this is quite an important slide here. I would just want you to have a focus on all these studies, but my focus over here would be on the comparator arm. I'm sure you had heard a lot of studies today, and almost in all the studies, the comparator arm still remains sorafenib, except for the last couple of studies. And as you can see over here, as the time has advanced, we talked about 10 months in the previous studies, and now we talk about the newer studies like Embryo 150 or Himalaya studies. See, the numbers are consistently going up from 10 to 13 to almost 14 in the checkmate 459. what it does tell you that the patient's outcome also are improving just because of the better, I would say, the treatment options which are available, better supportive system which are available. And that also has helped us touching those numbers to almost 14 and 15. So this has happened in the last decade or so, only with sorafenib. And now we also have other drugs, as we have already mentioned. This study, this particular slide is only to mention that whether it's a HBV, whether it's a viral versus non-virals, NFLD, the outcomes are not significantly different. So we need not treat these patients quite significantly differently in general in terms of when you tend to select the drugs. But here is one of the real life studies which did show that when the patient has non-viral advanced hepatocellular cancer, what happens is the patient with the lenvatinib had slightly better outcome as compared to the atezolizumab, both in terms of the progression-free survival as well as overall survival. So here seems to be some amount of data which seems to be generating where TKI may still have role in certain group of patients. What about the optimal sequencing in the second line setting? Now I'll just focus on the regorafenib as well as cabozantinib studies. Both are positive studies. Both had given us this, again, a survival of roughly around 10 months in both the studies. And these are quite reasonable and rational approaches when we talk about the TKIs in the second line studies. How about choosing? Regorafenib study has a second line. Cabozantinib has second as well as third line setting. Cabozantinib has been tried. And this is something one can think about it. I'll quickly rush to the slide because of the shortage of time. So kindly excuse me for that part of it. Now, okay, so in terms of combination, so sorafenib or placebo with a DEB test, that is drug-eluting bits basically. And here again, there doesn't seem to be any benefit of adding sorafenib over here as compared to the test. So this is practically a negative study. But when you look at the lenvatinib study with test versus lenvatinib alone, the outcomes are quite significantly better in the patients who received lenvatinib and test combination in terms of OS, in terms of PFS, also and in terms of response rates. So in all levels, this study has been a positive study. It's quite a big study, again, one can say. Now, this is something probably most of us in India even do today, where the patients do undergo combination therapy, wherever it is feasible, local therapy like TACE or TAIR in addition to TKI. So this is something quite an important data over here. And what about the newer TKI studies currently which are going on? And this is something quite interesting to know. Now, if you look at the LEAP 012 study, which has almost combined lenvatinib, pembrolizumab, TACE. So almost all, it's like a multimodality treatment coming together and just trying to understand whether outcomes are going to be better with this combination therapy. And along with that, there is another study which is again along with the atezolizumab. We have touched base a bit about neoadjuvant and adjuvant. The data is still emerging, still early days, but the main study in this space was a STORM study, which was a phase 3 study and which was a negative study. So we routinely don't use TKI in the early stage for now, unless there is some case-to-case requirements, something which has been alluded by the previous speakers. So what about the treatment of advanced SCC in India? Because that was my topic. Topic was more about how I'm going to utilize this particular treatment in the Indian subset. And we have our own unique challenges in terms of our patient burden, in terms of our lack of infrastructure, in terms of lack of facilities. In addition, there is always our headache of struggling for a certain set of patients who may not be affording the best possible treatments, like what has been discussed, like combination of immuno and anti-VEGF combinations. And here you can see quite a significant, almost 25% of patients. Now this is old data, and this is again may not have entire penetration, but there is substantial number of patients, people who are actually below poverty line, who may not come for the so-called the standard of care, and that is a problem. But since we know we have our own problem, we also have our own solutions. And that is the time we really need to look at our own Indian data in this regard. And this is one of the study which was presented by Kidwai, although a small study, but it did show that the patients who received sorafenib, of course, it is one of the older studies, 2017 study. Sorafenib patients had a better outcome as compared to the patient who underwent best supportive care. Those patients, very few patients who underwent combination of TACE with sorafenib had a phenomenally good outcome. Patients with the BCLC B stage had a better outcome as compared to BCLC C stage. And there is another study which was presented by Vikas and others from TMH. This was again to try and understand the tolerance of sorafenib in this group of patients. And what they could found was, again, the patients had quite a significant hand-foot syndrome, which is quite typical of sorafenib, and that is something what they could also show. And their outcomes, the median PFS was around 4.5 months, which also resonates with the Asia Pacific trial. So that was the outcome. Again, it was quite, these are only one of the small data which are available with us when you talk about the Indian perspective. And since the sorafenib is considered toxic, this was another study which was done by the same group, which tried to understand, can we reduce the toxicity of sorafenib? And what they did was they combined sorafenib with metformin with atorvastatin, the SAM protocol, what they have described over here. And what they could make out that the patients study using sorafenib 600 mg per day, actually with drug monitoring and with the combination had shown to reduce the adverse effects when we talk about sorafenib. So what I tried to show was what the data we have. We still don't have any data much about of lenvatinib from the Indian perspective for now in this setting. Now, this was one of the slides presented by one of our previous speakers, and that is again becomes quite important. Like we have mentioned, the outcomes of the patient can always be enhanced with the interdisciplinary action, which involves almost all the modalities, right from radiologist to intervention radiologist to transplant physician. And that is something what one should be practicing even in the Indian setting in order to maximize the outcome. This is something which also has been shown by multiple studies, how multimodality treatment or multidisciplinary treatment can actually improve the outcome of the patients. So what are take home for us when we talk about TKIs? Can we totally write it off now that we have got atezo-bev combination? The answer probably for India still remains no. I am sure most of us, almost I would say 70 to 80% of our patients are still on TKIs, vis-a-vis when we talk about the Western world. So there is a data for sorafenib which we had shown, which is again from the Indian data. Sorafenib still remains one of the important comparators for majority of the studies even now. I am sure the lenvatinib will eventually kick in at some point in time. And as I have shown, even with the sorafenib, the outcome seems to be improving as we go through from trial to trial, or I would say year by year, the outcome seems to be improving. Lenvatinib remains a robust first-line option even for us as Indian patients. Cabo and regorafenib remains option for second and subsequent lines. And we know that India is quite a price-sensitive country. India is an out-of-pocket country. Our patients, or one of the important issues remains the patient finances, something what we all do agree and understand. And accordingly, we tailor-make our treatment for the patient's outcome. So as we have mentioned, we all need to again build some data in this regard. Once you understand that there is no data, I think this is a good space to create some your own database and try and answer certain questions. So with this, I stop here, and I think I will not take any questions. Bharat, any questions? Dr. Senthil, I will request you, I think you are the last man standing, please. And Dr. Senthil is going to moderate the final session about systemic therapy in HCC. As he makes it to the podium, I will request Dr. Stalin, Indra, Bharat, Krishna Chaitanya. I think the rest is all yours. Santosh is there.
Avinash is there?
Yeah, please.
Is it? Santosh, Avinash, Rajesh.
Harish.
This is the list, or is this the list, or is it different? Because this keeps changing on the hour, every hour, isn't it?
So your time 9:30.
No, I'll finish earlier than that. So Rajesh, Amit is not there, Avinash, Santosh. Okay, never mind. You have a pen?
I have a pencil, sir.
You have a pen? Very good. My PPT, Jyoti should know because I've emailed her this morning, but if it's not there, that's even better. So just ask her. She must be question. Okay, great. So you've been seeing this. I just thought I'll show you a different version of BCLC classification, not because I wanted you to show something. Okay, so we'll get on to this case. Okay. We just have two cases. We'll finish by 9:20, right? Because it's sleeping time for me. 76-year-old lady, hepatitis C, positive, off treatment for hepatitis C, chronic liver disease, obviously, child fuse A, BCLC-C. She's BCLC-C because she was symptomatic for this. The performance status was 1. Because if you remember, in all the others, you'll have to have a performance status of 0. That means they've all been picked up when they were asymptomatic for the hepatocellular carcinoma. Upper GI endoscopy was done. Grade 1 varices. Stalin, what would you do next? Okay, you can answer those questions, no problem. Whichever you choose. Not doing both of them. Okay. If any reason, so who in your practice gets a biopsy? Would you ever do PIPCA or not? You've not done so far. Excellent.
Biopsy, the learning of the next, the real answer features are suggestion of the next. If there is anything which is suggesting that it's not a classical looking at it,
So whenever it's not classical looking, let's say somebody has got chronic liver disease with hepatitis C.
I'm not doing.
You're not doing a biopsy. Excellent. Bharat.
If the radiology is classical, arterial hyperenhancement with venous for sure, I think that is.
We're not doing a biopsy. We're not bothered about AFP levels in order to make a diagnosis of HCC, correct?
But as long as the radiology.
As long as the classical one is there. So do we do other tumor markers? Let's say, would you routinely do CA 19.9? Chaitanya.
It's like not classical of HCC and AFP is normal. You have to see whether there is a combination of internal hepatic carcinoma. That's a combination. So at that time, maybe you should do other tumor markers also. CA9 along with AFP. And PIVCA also will help sometimes.
PIVCA will also help.
And in both of them are raised maybe more specific towards HCC.
Okay. Yeah, go ahead. Go ahead.
The background of cirrhosis.
Okay, we are coming to background of cirrhosis. So is chronic liver disease different from cirrhosis? Correct. So excellent. Okay, if you want to apply lyrides, then you have to have a nodule of more than 1 centimeter. Excellent. Super.
If there is no cirrhosis or normal HP, we do a biopsy for 2 reasons to confirm and any component loss.
Okay, excellent. So this point is something that keeps coming in our tumor board every other week whenever we have somebody like this. So Stalin spoke about CLD. Cirrhosis. Cirrhosis is one of the stages or clinical manifestations in that spectrum of CLD. So let me tell you what is the criteria, NCCN criteria for biopsy. One is what Stalin clearly said, if the radiological criteria for diagnosis is not clearly met. Okay. Now this radiological criteria is to be interpreted only with background cirrhosis, not all chronic liver diseases, because you are looking at chronic liver disease with hepatitis B as one where you probably don't need to do a biopsy. But if it's just chronic liver disease plus hepatitis C, by NCCN, you are supposed to do a biopsy because the incidence of hepatocellular carcinoma in hepatitis C chronic liver disease or hepatitis C positivity only is not very high. So this radiological criteria, or LIRADS as they call it, is applicable only in conditions where there is cirrhosis, or if there is chronic liver disease where the incidence of HCC is extremely high, like hepatitis B. Let's say somebody's got Budd-Chiari syndrome with cirrhosis. Let's say somebody's got congenital hepatic fibrosis. Let's say somebody's got cardiac cirrhosis. These are situations where LIRADS does not apply. Okay, it does not apply in children. It does not apply in nodules which are less than 1 centimeter. Okay, CA19-9, the reason why I asked you is that if your radiological features are not typical and your CA19-9 is elevated, that's another reason for biopsy. Okay, so typically the cirrhosis that we see associated with NASH, cirrhosis that is associated with hepatitis C, cirrhosis with hepatitis B, all those congenital metabolic disorders and all which can lead to cirrhosis. So the easy way to remember is any cardiovascular cirrhosis, you typically need a biopsy. Cardiac cirrhosis, vascular cirrhosis, you need a biopsy. Okay, even if your tumor is looking very typical because LIRADS does not apply there. So by NCCN, this lady actually needs a biopsy. So that's the point. Okay, where you don't need a biopsy is clear cirrhosis, chronic hepatitis B with chronic liver disease. There you don't need cirrhosis. These are two situations you don't need if your radiological features are very typical, as Bharat said. Are we clear about that? Okay. So in the other situations, yes, Kaushik. Absolutely. So the reason you're right. In fact, the other point that we should make is that all these LIRADS is not in patients typically that we see, huge tumors, stage 4 tumors. In fact, there is a nice series from the UK, 471 patients. They went ahead and looked at criteria and then they biopsied all of them. 9% were something else. So there's a good possibility that you're going wrong if you don't do a biopsy. And then, now everybody wants to do NGS. You look at, those tissue agnostic markers for use of all these therapies. So Kaushik is absolutely right when he says that the number of patients who are having a biopsy now is increasing. Okay. Puika, anybody, Rajesh, Puika. Does anybody know the expansion for PIVKA? I've been mugging it up for the past 48 hours. I'll tell you. Super. So protein-induced vitamin K absence or vitamin K antagonist 2. Okay, I believe there is one. So it is 2. So that is what PIVKA is. But as Stalin rightly said, we don't routinely do it, but it's really an upcoming marker. And if you see anybody from AAG, they will have a PIVKA there. Okay. So if somebody says my PIVKA is high, I know where you're coming from. Right. So it's a marker of coming from AIG. Yeah. So, but the sensitivity and specificity of making a diagnosis increases if you're using both markers. So I think in the future, we will use both of them more often. But again, for you, very important is diagnosis does not depend on markers. Please remember this. There was a time when, I was a student, you had to have 2 radiological investigations with an AFP of 400, you can make a diagnosis. That's not there anymore. So you don't have to have a marker being elevated to make a diagnosis of cirrhosis. So we're clear about where we need to do a biopsy, where PIVKA and biopsy comes. Okay, let's move on. So I won't ask you to interpret this scan because I myself don't know how to interpret. I thought some, radiology people will be there. So don't bother about those scans. So you will get a report like this, okay? Chronic parenchymal liver disease with portal hypertension. There's one LIRADS 5 lesion, multiple focal LIRADS 4 lesion, high probability of HCC, and then there's some focal lesions on the left side. So anybody wants to take a call on what's the next step? Anybody is fine, anybody. So one lyrides 5, multiple lyrides 4. I didn't do biopsy because this was before this panel discussion. Okay.
And
Okay.
so systemic therapy is the treatment of choice.
Systemic therapy is the treatment of choice. Bharat,
Yes.
systemic therapy. Anybody wants to contest systemic therapy? There is no vascular. That's why I said vasculature is normal. I've written that because that's not in this report. Okay, so there were so many things that were discussed as part of this because there was no clarity on how many of these nodules were actually hepatocellular carcinoma. So that's where the problem started, and the vasculature was normal. So a lot of discussion was on whether TACE should be done or not. Okay, because even if you have multiple, as long as these are all small nodules, it's okay to go ahead and do TACE. But as the number of nodules keep increasing, the efficacy keeps going down. We know about it. So again, she ended up having TACE, but the beauty is when they put the sheath and then they gave the dye, you just found that the liver was studded with nodules. Correct. I know, I heard your voice on the video. Right? Okay, but that's good because we learned. Because for the first time, I learned that you could pick up. I want you to comment on that, please. Because the first time, I at least learned that when you do something like an angiogram, look at the way that liver is just studded with nodules. So you just want to add something, yeah.
And then they can do it as a video. This was patient came from Asata.
Correct.
And he was just,
It's because the aunt of one of my residents. So
this is what you were opinion of patient days.
excellent.
This is the only city units.
Correct.
Which we have taken. When only city, we go into the hepatic card, common hepatic card, and give a contrast and take a diagnostic data. So in this region, actually, we didn't want to do this, but we wanted to see how it looks on community because there were multiple lesions was on camera. But when we did the community, the first image, that's the community image, there were probably more than 30 or 40 lesions which were enhancing in the community. And they were excellently arterially enhancing lesions. And those were, I think, more than 30 or 40 lesions were there. And now go ahead and days and
Lovely.
So now this become a main role that we are doing only for each and every.
So that's where we're getting to, right? So sometimes what meets the eye is not what you're actually seeing or what is actually there. So in such situations, I think an expert like him is necessary to tell you that this is not a patient for some kind of local regional therapy. It has to be systemic therapy. So I tried to convince my resident that no, systemic therapy is what we should be doing, but knowing me so very well, she didn't believe me. So she went and had that whatever angiogram or cone beam CT and so on and so forth. And then fortunately, I turned out to be right. Anyway, never mind. So that's what it was. Okay. So anyone, Rajesh, what shall we choose for this lady? Upper J endoscopy showing grade 1 varices, never ever had a bleed. Fine otherwise. No contraindications to immune checkpoint inhibitor.
No bleeding tendencies.
Mike. No bleeding tendency.
Cost is not a concern.
Cost is never a concern in a panel discussion.
Right,
It's only in the clinic.
Right, first followed by.
No, what first? Stride first, followed by atezolizumab. Why did you choose stride in this patient over atezolizumab?
We are not sure of the portal pressures. So many labor balances the tendency to bleed how much we are not sure. And the bleeding risk is relatively less.
So are we saying that in every patient that we want to use atezolizumab, we will do portal pressure measure? I've never done it in my life. I don't intend to do one also.
No, I don't need. What I need to say is when we have both the options available, as it is the panel discussion, I wanted to put a point. Whether the bleeding risk is more.
So grade 1, usually it's not correct. So no problem. Bharat has said no problem. So then what? Atezolizumab. Why did you choose atezolizumab over Durva and tremelimumab? Because today is Roche meeting.
No, meaning my hands-on experience with
Okay, your hands-on experience, lovely. So that's a very important point because we've been using it for some time. We know that regimen a little better compared to Durva and Tremi, because at least I have not seen Tremi so far. We don't have tremelimumab in our place. Okay, so that's why we are using atezolizumab. So here is some, okay, slide. Yeah, Bharat?
Sir, probably
Ah.
a bit more efficacious in terms of response rate, 30% versus 22, disease control rate 70 versus 60, PFS improvement of 7 months, no improvement, and most importantly, 19.2 versus 16 months. Then all the parameters slightly better, and if there is any contraindication to be anti-VEGF, then only we should pick up. Slightly better in terms of all the parameters, although both have a level.
Both have level 1 evidence, but in terms of cross comparison and numbers, atezolizumab seems to be better because the hazard ratio is vastly better. I would say 0.59 to the latest, correct, 0.78, 0.59, and then your response rates are better with atezolizumab. PFS is not significant in the STRIDE, while it is significant in the IMBRAVE 150. Like in any other immune checkpoint inhibitor only study, PFS is never positive, but you will get an overall survival that's better. As you rightly said, overall survival is better in both, but the numbers look to be a little more impressive with the atezolizumab compared to the STRIDE regimen. Now, I wanted you to look at that last column, which I updated yesterday night. I want you to look at the overall survival that you have gotten in the Len-Pembro study or the LEAP study. The LEAP study was negative, Len-Pembro versus Len. Okay, addition of Pembro to Len, at least in one side, did not show improvement in overall survival. Otherwise, whenever you don't know what to do, you can use Len-Pembro. It's becoming the next paclitaxel, right? So what I was very impressed is response rates are as good. And you see the overall survival, 21.2 months versus 19 months. 19 months with lenvatinib is simply a superb number. What you would get routinely with lenvatinib is somewhere around 13 months. You're getting 19 months. So what's important to keep in mind is that when you're cross-comparing all of this, you have to do it with a little bit of caution, right? Because the patient populations are different. The number of patients with viral etiology is different. The number of patients with main vascular, involvement is different. All of these are very important prognostic factors. So when it comes to Santosh or one of you, when it comes to viral versus non-viral etiology, is there some difference in the way immune checkpoint inhibitors work? Or, Satya spoke about, I believe, as always, he did a great talk. So do we have some information on the efficacy of immune checkpoint inhibitors in viral versus non-viral? So this Zoom is kind of making a mess today. Correct.
Atezolizumab combination was whereas STRIDE, irrespective of the etiology, works even in non-viral, except in hepatitis.
Except in hepatitis C. Okay. Yeah, Bharat.
Immuno was better in viral.
Okay.
So in any trial, if you have more of HBS or HCV, probably in that trial, the immuno result will be better. Now I'll go back and tell in IMBRAVE 150, if you take the non-viral, it was 15 months only versus more. So probably we can also emphasize the same point. Non-viral, probably Len is as good as immuno.
Non-viral Len is as good as immuno. Okay, we are making a sweeping statement today.
Sir, that's what literature.
That's what literature says. Okay. Okay, literature says that you have to interpret.
There was a Chinese study, camilizumab is one of which was the reason. It went to 23 months because more was the number of virus. Just to put my point.
So the first thing is, generally, if you look at any of these studies, you will find that about 65% of patients will have Hep B, Hep C. Okay, while in our country, we just put together a set of 140 patients, of which a lot of were contributed by, Vamsi's group from AIG. So in that, only about 35% have viral etiology for HCC. This is point number one. Point number two is, in general, it looks to be that immune checkpoint inhibitors don't work that very well in patients who have non-viral etiologies. It works best in hepatitis B. If you see this forest plot, it's kind of so very consistent. Okay. In the non-viral etiologies, the efficacy doesn't seem to be as good as what it is in viral etiologies. Now, we have to interpret this with a lot of caution because these are not planned subset analysis. These are all post hoc analysis. In the viral, we don't know how many had active, how many were on treatment, how many had completed treatment. In the non-viral etiologies, how many was alcoholic, how many was non-alcoholic steatohepatitis. We still don't know that granularity in terms of data. But as a general rule, it seems to be that immune checkpoint inhibitor based treatments are not the best treatments for non-viral etiologies. So when you're looking at your next patient, you need to think about it a little. Sorafenib seems to be a good drug for hepatitis C, especially. And whatever Bharat was talking, sorafenib seems to be much better drug in if it's non-viral also in some of these subset analysis. But keep this in mind. Don't go tomorrow and say you've got non-viral etiology, so I'm going to use sorafenib. That's not the point I'm trying to make. The point is that limited efficacy in patients with non-viral etiology. So that's what it is. Okay. So what did we do for that patient? She went on atezolizumab and she had some tumor shrinkage. Obviously, AFP was normal, so we couldn't evaluate that. She's been going on now. It's nearly a year. Must be nearly a year, I suppose. Yes. So kind of decent because the PFS is about 6.5 months. So she's crossed that PFS. So we're happy that she's crossed the PFS. Is going on. She's hepatitis C. So B is the best. C is a little less non-viral, point estimate kind of comes to the center. But Rajesh made the right point that Himalaya seems to be showing, benefit even in patients with non-viral etiologies. Again, as I said, interpret with caution. It could just be by chance. Okay. So that's about the first case. We've got 5 minutes. Nikhil is giving me a dirty stare, so I will stop very quickly. No, 3 minutes. Super. Okay. I'll quickly run through this. I just wanted to ask only one question. How would you proceed? I'll ask that at the end of this. 72-year-old male. He had NASH, CLD, BCLCB. CP was 8/9. Okay. AFP was just over 1,000. Bilirubin was 4.1. Diabetes, hypertension, CKD, everything you want. Upper GI scopy, grade 3 varices, portal gastropathy. He underwent microwave ablation. Okay. Now, after microwave ablation, he had an MRI done in May 2023, non-viable lesion. And I think there was a portal vein thrombus, if I'm not mistaken. Yeah, there was a portal vein thrombus. So the AFP came down to some 600 plus. And then we did the AFP and we did a PET CT because the AFP was shooting up 21, 28. So 1,100 to 600 plus to 2,128. So that's what the PET CT is showing. It's just showing the same lesion. There's nothing. We did a PET CT because I was just thinking there's disease dissemination somewhere else. And, that was the thought process. So what would you do in a situation like this? The PET CT is also showing that it's just a residue. It's not increased in any way. It's actually a little better than what it was earlier after the microwave ablation. And the previous MRI actually showed that the whole thing is dead and gone. So what would any one of you do in a situation like this? Would you chase the AFP or would you say, hold on, let me see what happens next time? What would be your, just tell him. You will hold on for some time?
I'll start.
You will start.
Because by the time probably that golden task once they start with it.
Okay.
Protein is rising. There is a disease that you can't rise without a viable disease to more than 2,000.
I'm saying the chronic liver disease is worsening.
Less likely.
Less likely. So again,
For up to 400 probably, or up to 200, it could have been a 2,000, more than 2,000, probably some amount of disease. Earlier the better. I now probably.
Earlier the
better.
Okay. Anybody from this table wants to differ? And if you're starting therapy, what would you decide to start? Rajesh, Santosh, Avinash, anybody? Okay, Avinash is not there. Rajesh, Santosh, Harish. Sorry. That's why I've got it to the expert panel. Expert panel. See, BCLCB, correct. We don't know where the disease is. AFP is rising. Start sorafenib. Okay. Both of you, sorafenib? Lenvatinib. Rajesh, lenvatinib? Lenvatinib. All lenvatinib. So nobody is for Himalaya. You will start Himalaya. If I'm going to start it, I will start it, but for this patient, I'm not starting. Yeah. Local therapy, one local therapy is done already. Microwave, yeah. Correct. So
Another question on phase, because it was ablation was done. Sometimes the microvascular invasion cannot be taken care by microvascular ablation. So I would go ahead and do a case for it with them.
So radiation. So I should ask Sujana, you said you're not the expert in that. Hang on. Hang on. You're the boss, but she's the expert. No, go ahead, Kaushik. So no, because we did discuss about, firing it once more. Another form of local therapy before we decide to go to systemic therapy. Point very well taken. Okay, side by side, we'll come to anybody agrees with Kaushik, side by side, do SBRT, let's say, or TACE or whatever it is, and then combination. So there'll be 3 therapies.
Simultaneous is always better. We should take it from this lot study. It has to be, I'm going from P to P, but whenever you give better, second dose, I will start along with the T.
Okay, so systemic therapy along with SBRT or TACE or one of the liver-directed therapy. That's a nice way of saying that. Okay, so that's what we have actually suggested should be done because the PET is not showing anything, but that AFP rise is kind of a little uncomfortable. So remember that this kind of a jump cannot be because of chronic liver disease. Okay, a doubling in 3 months is good enough for you to say that this is only the cancer that's causing the AFP increase and it is not the chronic liver disease that is causing. So what we are planning to do is we are planning to do lenvatinib, not sorafenib, and then do SBRT because as I was telling Kaushik, we don't have anything else in our hospital. So the radiation oncologists take the cake. Not because they're also good. That's why I said. So yeah, we decided to do it, don't we? I'll next panel discussion, I'll tell you what happened. Chalo, lovely. So let's quickly revise. Any other points that anybody wants to make because 9:30 will stop. Okay, so yeah, please go ahead. Okay, angiographic blood will reduce. So 2 weeks before, 2 weeks after, is it? Just 2 weeks before. And then lovely. So that's a very nice point. So that's good learning also. So when to stop these. I think that's becoming the rule for everywhere that you are doing SRS, I suppose, because any TKI wash out, correct. So stop, do and then stop, correct. Because correct, because they're looking at the half-life, isn't it? Some people think it's nearly 3 or 4 half-lives that you have to actually wait before. The reason is of late, the major problem we are having with SRS and the brain and lorlatinib. In the past 3 or 6 months, we've had 2 craniotomies, post-SRS, post-lorlatinib. Both of them tended to be radial necrosis. One lady was operated because she had midline shift and all those things. So typically we've started stopping the drugs so that we don't get into trouble like this. Okay, quickly, let's revise for junior people who are confused at the end of this discussion. First thing, biopsy. Biopsy or not, if classical etiologies, there's cirrhosis, there's hepatitis B, chronic liver disease, and arterial enhancement and washout in the venous phase, you don't have to do a biopsy. You don't need an AFP or a PVK to make a diagnosis of hepatocellular carcinoma. Radiology is just good enough. You don't need 2 radiologies, you need 1 radiology that's good enough. Important point. All vascular cirrhosis, LIDATs don't apply, you'll have to do a biopsy. We've started doing CA19-9 for all our patients with liver masses now, and anybody who's got an elevated CA19-9 will also end up having a biopsy. And then you want to do NGS and all that stuff. And then some transplantation surgery for all that, they will do a biopsy, but that's a little beyond our purview. Okay, so PVK and AFP together are complementary. When you do both, your sensitivity specificity improves. And PVK can be used to monitor in situations where AFP is negative, like in our first patient. Atizo, Bev, and Himalaya, we just don't have any comparison to say that one is better over the other. Numbers seem to be favoring I Am Brave 150 at this point in time. We'll have to wait for longer follow-up to see if Himalaya will get better over time. But both have overall survival benefit data, so it's category 1 for both of them. Wherever there's a contraindication for VEGF, or wherever there is contraindication because of high chance of a bleed, and there's no contraindication for use of an immune checkpoint inhibitor, Himalaya would be better. The other thing, again, based on subset, is Himalaya seems to be working in patients who have non-viral etiologies. In general, immune checkpoint inhibitors don't seem to be great interventions in patients who have non-viral etiologies for hepatocellular carcinoma. But that's post-hoc subset analysis, not to be used for decision-making at this point in time, but keep that at the back of your minds when you're counseling your patients that the data is not so great. Post-loco-regional therapy failures, if you're evaluating and that you're finding that your disease is still confined only to the liver, one more repeat order or get to another form of loco-regional therapy and then think about adding your systemic therapy. Okay, so that's how we will do, treatment in a situation like what I've described. So I think we will stop there, and thanks, Nikhil. Thanks, Vamshi. Okay, Vamshi is on the flight.
Thank you, panel members, and thank you, sir. I think two roles to play a very difficult role, I think, in this any session, any conferences. One is a program director. Second one is any chairperson, I think. So they have to sit from the session starting to session ending. At the next one is the last one is if anybody asks you to do something concluding remarks. So you have to be there from the starting of the meeting to end of the meeting. So that is a role I am going to play now. I think Dr. Vamshi, I think, clearly mentioned how to evaluate a case, because so many police are here. How to evaluate a case of suspected liver cancer. I think he mentioned clearly. Again, Senthil sir also concluded very nicely that where do you want to do the biopsy and what are the indications of the biopsy? Can we avoid the biopsy in certain areas? And I think there is no ambiguity in that one. Of course, coming to treatment wise, yes. Yeah, in 2005, when I joined the medical oncologist, Senthil sir was sitting in OPD. So one police DSP, something is a DGP has come with some reports. He said, sir, I have some diagnosis liver cancer. I don't have any financial limitations. I have this Aragabatra scheme. I think there is no 2005. I think he said, so I don't have anything to offer other than the best supportive care. But patient was very good in general condition. Since these are advised on the best supportive care, the fellow he survived for more than 2 to 3 years without any treatment also. And in 2005, now we have so many medications. And again now we are talking about all the issues, something like recent advances. I think Sorafin came into the picture 2007. Still, there is a role. I think Nikhil clearly mentioned where we can use this TKIs. So definitely, I think our international speaker he mentioned that one around more than 90% of the population they'll use only immunotherapy and other what you can say bevacizumab. But in contrary to this, is vice versa in our country. I think there's more than 90% will use only TKIs. And only 10% they can. But whatever it is, ultimately, we have our own limitations. But still, whenever we discuss about the scientific agenda, but still, Nikhil, I think, first time I think Nikhil, he meant to has taken a different topic today. So you clearly mentioned where we can use this. Again, he mentioned this BPL one graph also mentioned very nicely. Definitely, we can consider in certain areas without any hesitation. You can start TKI. We have so many generic TKIs are there. So Nikhil, he mentioned very nicely. And the next one is Kaushik Bhattacharya. He's very much upset about because there's no radiation oncologist in this BCLC. So I think in that again definitely you have taken your points are well taken, because nowadays everything is multidisciplinary. Everything is, even you mentioned there is no role of RT in something. Again, you mentioned something because of the radiation oncologist not there in the committee. So there is no radiation role is there. I think you have mentioned very clearly in this one. So okay, but yes,
they are more balanced compared to the sales.
Correct. So I think because this is an open discussion, at the same time, all of us were open to discuss, and ultimately we should not ignore the role of radiologist and intervention radiologist. I think clearly they have mentioned what are their exact roles here, and very nice. Yeah, because I think this is multidisciplinary. Always oncology is always a multidisciplinary approach. We can't just say it's a medical oncologist, radiation oncologist or something. Everybody they are playing a good role here. But ultimately, one more thing is I think you have discussed liver-directed therapies very nicely, sir. Your panel also discussed very nicely. Dr. Krishnamani, he mentioned about adjuvant therapies. I think nowadays the adjuvant therapy also come into the picture. RCC now everybody they said high risk TKs went down. Now the immunotherapy is coming up. Here also there's people they said immunotherapy also has some role in adjuvant setup also. I think you should define the which subset of the patient they are going to benefit with this adjuvant therapy. Next one is I think Amit Singhal he mentioned from studies, all the studies he mentioned, like he discussed almost all points from diagnosis to the adjuvant also he mentioned. Thanks to the international speaker and as usual, Nikhil, I think Nikhil already mentioned number of times. Okay. And Vamshi already mentioned, Vamshi's initial introduction I mentioned already. So don't worry about it. Because as a program director, I have mentioned his name as an intervention areas I mentioned already. So because liver directed therapies are important nowadays. I think where to play, where I think we should know our limitations also, where we can't do some of the things. And ultimately, Senthil sir, I think his panel is always I think nobody can explain in words. So because it's a he started from the diagnosis to this. But one more important thing is I think sir, international speaker in his talk, I think what he has mentioned, irrespective of the viral etiology or non-viral, you can use this one. I think you have made a clear point. One is something non-viral, less benefit than the hepatitis C, then hepatitis B, something. I think this is but still there is a role if you have definitely. And that I think all the panel members, they played a wonderful role. And as so thank you once again for this giving us opportunity, especially Roche and Simpla people also here. I think maybe it is especially this Asha has played a major role here and other people also. Thank you once again for each and everyone. Anything? Done? Dinner? Okay. Thank you.
No, it's not. Can you, Krishnamani's presentation, can you this pen drive? Dr. Krishnamani.
One second.